Priya, are you there? So, Shobha ma'am, you can start, ma'am. I
think
Yeah.
Dr. Parag, it's
You
written.
can invite Dr. Parag. Mandakini ma'am is here.
Yeah.
So, you
Let me start. Good
Could we
afternoon.
start?
yeah.
Yeah, and welcome to
Right.
the second day of our ICOG certification course on menopause. So this is one activity which is going on for this is the fourth year now, and I'm happy that one Dr. Mandakini Meg is here today because she was the one who initiated online activities, and now ICOG is known for all its online activities. I must appreciate efforts put in by my conveners of this course, Dr. Shobha Gudi, Dr. Archana Dwivedi, and Dr. Geeta Balsarkar. I think let's begin with the second day. Okay, Archana, are you going to introduce Dr. Saraya and Dr. May, or who's going to do it? Priya is going to do it.
Priya is going to do that, sir.
Yeah.
Priya, mostly for today, I'll invite Dr. Priya Thakur to invite our guest.
If I could request the tech team to give me the CVs of Dr. Saraya Madam and Dr. Meg.
Yeah, she's doing that. Just wait.
So with great pleasure, I would like to introduce Dr. Usha Saraya Madam. She's a consultant obstetrician gynecologist at multiple hospitals in Mumbai, and she has also started the cytology clinic at Karma Hospital in 1970. She's a founder, member, and past chairman and past president of ICOG. And she has achieved a number of international awards as well as national awards for a credit. Dr. Saraya, Madam, I would please request you if you could address the delegates with few words of wisdom from your side.
Can you hear me, Priya?
Yes,
ma'am.
Madam.
Yes, thank you so much for this kind invitation. It's my pleasure to join this workshop. And I would not take much of your time because you have so many speakers who are going to give some very good lectures. So just 2 points I would like to talk about. One is ICOG and the second is menopause, because these are the two relevant points for today's discussion. Now, as a founder member, I've been with the ICOG for the last 40 years since its inception in 1984. And I've seen how well the Institute has grown and how they have brought out the best of medical education and given it to doctors all over the India who are students, postgraduate students, and also practicing doctors. And this is what I call the informal sector of medical education. It is totally voluntary. There is no compulsion. The teachers are voluntarily teaching and the students are voluntarily learning. And it is today one of the foremost institutes in India which is imparting education in obstetric gynec. Fellows are very well trained and they are giving services all over India, rural and urban areas, and improving the health status of our population. And that was our primary aim of starting this college. And we thought we will improve their knowledge so that it will translate into better practice. And I'd like to congratulate all the presidents and chairpersons of the last 40 years. Especially, I would like to thank Dr. Parul Kotnawala, who is the current president, and Dr. Parag is here with us, who will be taking.
Yeah, looks like Madam got logged out.
Some network issues probably. I think we can request Mandakini ma'am is here with us.
Yeah, please introduce Dr. Meg.
Can I have yes. So with great it's my privilege to introduce Madam Dr. Mandakini Meg. She's chairperson of ICOG Foxy 2020 and to 21, International Vice President MWIA Central Asia. She's National President of AMWI, and Madam is also a Vice President, National Vice President of Foxy. She has been in 2012 and 2013. Dr. May, we would request you if you could say a few words to the delegates.
Durgadas ಹೇಳಿ.
Yeah. Can you stop
Dr.
sharing?
Mandakini May.
Yeah, can
Madam,
you stop
yeah.
sharing me? So I think Madam Usha Saraya has joined. Madam, can you want to finish your talk? You are muted. Madam, you are muted. Madam, you are muted.
Nilima, help her unmute. Sometimes what happens, we are trying, we are not able to unmute. Please help her unmute.
Okay.
Yes, yes.
Yeah, now can you hear me?
Yes, madam.
Uh,
Yes.
did you hear me when I was speaking? I asked Priya. Priya said she can
Yes,
hear me.
we could
and
hear
suddenly
you.
It went off again. It went
Yeah,
off.
suddenly.
Last 2
Shall I-
minutes we have not heard you, madam.
Huh?
2 to
Just
3 minutes
last
we have
one,
not
yeah,
heard.
2
So,
minutes.
no, I was just saying a few words about ICOG. Did
Yes,
you hear
ma'am.
that?
We heard you till you spoke
I
about.
said about that. Yes. So this ICOG is a very strong edifice with very strong base, foundation, and it has very strong pillars. And we hope this will continue and continue to educate the people. Now I come to the second point, which was is about menopause. We all know that 1/3 of the life of a woman is spent in menopause. It's a very significant factor. And as the aging process is going on, the people are living late into their 70s and 80s. And we must make life worth living. If they're going to live, they should have a meaningful life without any health issues as far as possible. So it is also, there is another aspect to it. Currently, the women are entering the workforce in a very definite manner, and they are holding very important posts. And in their 50s and 60s, they are at the peak of their careers, and they are giving excellent service to the profession, to the banking sector, to the bureaucratic sector, and it is not possible for them to do these responsible jobs if they are not in good health. So we have a responsibility to the women who are holding high posts and working and doing responsible jobs to help them cope with their assignment and give them the best of care. And also the care has to be definitely safe and in their long-term interests. So all these things will be discussed in this very worthwhile workshop, how best to help them, how to make the conditions safe, not harm their long-term prospects of health. And once you start with these ideas and once you get confidence in the treatment of these things, I'm sure your patients will be at a great advantage and they will be able to do their work satisfactorily. And many people, even after retirement, don't exactly go into retirement, but continue to hold important posts. So we have to be aware of all these changing attitudes and changing factors in our society. So I congratulate all those students who have joined this course. Enjoy every moment of the course. Enjoy all the discussions, participate actively, and give your best to the course and take the best from the course for you to practice. And I once again would like to thank the organizers for giving me this opportunity to share my thoughts with you and wish you all the best for the course today and anytime you hold the course. Best wishes are with you. Thank you. Thank you, Priya. You can take over.
Thank you, Saraya Madam, for those wonderful thoughts. Now I would request our guest of honor, Dr. Mandakini Meg, to please say a few words.
So, good evening, madam. It's a great pleasure for me to share the screen with our, mentor and guide, Dr. Usha Saraya, madam. I think it is a very good opportunity, and I always look forward when Parag is around. So, yesterday also, I think at somebody's place, we were discussing, we were the winning team, and whatever actually Parag has said that we have started this with, lot of difficulties when there was lockdown, and we were not knowing exactly how to go about it because we have discussed so many plans and all were going haywire. Nobody was knowing about the Zoom, and we were the first to start the Zoom, the lecture series, journal club, and so many activities online we have started. And today you can see how beautiful it is blooming. The format, Parag will remember, the format was formed because initially when the 2 days course or 3 days course, pre-test, post-test, there were a lot of trial and errors. And after trial and errors, this 3 day course format was decided, and question answer MCQs and variety of subjects were put in. And after that, I think it is just taken off very well. And today what we are seeing is wonderful. As madam has said, ki everybody is benefited, and we are doing selfless service. Students are also taking the classes. Apart from our reproductive medicine which we have started, there everything is centralized teaching. So this corona indirectly was very beneficial for the, madam, I must say, for the ICOG. And we all came under one roof. We are united and see the amount of work which is being done, carried forward, and extremely happy that Parag will be taking over as a chairperson. I acknowledge the presence of Shobha Gudi, Priya, Ashwini, Sarita, Parul. We had a fantastic conference. I remember when I was having the food in the ICOG conference in Ahmedabad, one of the students, he came to me, madam, those courses which you started, which we like specifically PPH and the operative obstetric, madam, so beautifully you all were taking classes, and we all were glued, and our time in the corona has gone so beautifully, learning from so many. I think Arul Kumaran used to come for every alternate this thing. We had all international, national, RCOG, and wonderful time we had. So I think madam has already spoken about the menopause. I need not, elaborate. And it's an extremely important part. I have given recently the keynote address on the post-menopausal therapy and the hormonal therapy. And we know the importance of, treatment and, well-being in the menopause. I see so many beautiful lectures are already pending. And I think I should now say, thank you very much, Parag. And I will be in your period, Sarita. I can see the Sarita also. And I want to really be a part of your, ICOG very actively whenever possible. So, madam, thank you very much. And everyone for inviting me, Geeta. I can see Geeta also. So, thank you, Parag, for this kind invitation. Thank you.
On behalf of the office bearers, Sarita is also joined. Thank you, Madam Saraya, for being here today. You always inspire us, and I've said it time and again that your enthusiasm, even now at this age, is infectious, and we always learn from you. Thank you, Dr. Meg. Uh, we are nurturing a baby which was delivered by you, and I hope this continues in the long run. Thank you very much. Over to you, Sarita.
Yeah, thank you, Parag. No, I won't. I don't need to say anything. Just thank you so much to Dr. Saraya and Dr. Mandakini Meg for joining. And I really remember that I have worked very closely with Dr. Meg in ICOG, and that is what made me go for this post. And I really thank her for all the encouragement and everything she's done. I think we can go ahead then with the pre-test.
Yeah. So I think Nilima, please share the pre-test for today.
Madam, revision by.
Yeah,
Shall
Shobha will
Shobha
revise
madam
it
will.
and, at 4:20 we'll start the pretest.
Yeah. So can I
Shobha,
just
can you- yeah.
take a few minutes on revising the topics? Not exactly revising, but just a recapitulation of what has been dealt with yesterday. To begin with, let me thank Dr. Parul and Dr. Sarita, Dr. Parag, and Dr. Sheila Mane for giving us this opportunity to conduct this excellent program. It has been in discussion for so long, and now it has come to fruition. And I think, as Saraya ma'am said and Dr. Meg said, all delegates should feel fortunate that such a subject is being dealt with. I do remember, Saraya ma'am, when you were president, you made research as the theme of your year and publication. And I really distinctly remember how you encouraged everybody to publish their work. And I was very motivated by your theme. I thought it was something very unique. I also remember the oration that you gave, the presidential oration, and you said you spoke on PAP actually, and your speech actually brought tears to the eyes of the audience, because you spoke about how they came up with the cytology and the invention at that time. Meg madam, thank you for coming here today, and your tenure as chairperson was indeed very, very remarkable. We all remember that. To speak about the first day program, Dr. Shaijas began yesterday, and he brought out very beautifully the Strauss plus 11 staging and the clinical application for it. Of note was his take on menopausal transition, actually. And Dr. Lakshmi Ratna's talk on premature menopause after that was also very much in detail, with very good, flow charts of investigation and management. Vasomotor symptoms, where Dr. Ambuja saw all the recent advances. And as Madam is the past president of IMS, she brought in a lot of knowledge into that subject. The lifestyle management by Neerja Chawla was actually very deeply spiritual. Everybody felt really moved by the way she brought in the spiritual element, and also the importance of epigenetics and genetics. After that was actually the exercise queen of IMS, and that is Maninder Ahuja, and we always remember her as Mandy on the move. And she really told us very, very precisely what works for menopausal women. Thank you for that, Maninder. And Neeta covered, of course, as her expertise is urogynecology, she covered the OBS very, very well. Then Dr. Neeraj spoke in a very sensitive manner about the investigation of women in midlife with sexual health problems, and that came out very well. And cancer prevention for both the ovary and breast was dealt with by our esteemed past chairperson, Dr. Lakshmi Chikande. She brought in the latest investigations into that. And of course, the secretary, Dr. Sarita Bhalerao, very, very practical demonstration of evaluation of postmenopausal bleeding, especially the hysteroscopy part of it. We are very grateful to her for that. And the post-test questions were also very astute. I hope all of you have performed very well. With that, I hand over to Dr. Geeta to conduct the next session.
Thank you, Shubha Guri, madam. And now we'll have the time for the pre-test day 2 topics. Tech team, please take note of that.
Okay, yeah, thank you. Laurie, please post the test, yeah, and put the timer on. Hello, Geeta ma'am.
Yeah.
Yeah. Can I share the screen?
I think Geeta ma'am, we can start the session. Priya is having some network issue, I think.
Priya is
No,
having a network
am I
issue.
audible? Am I audible?
Yeah.
Or audible.
Yeah. Priya, you're audible. Yeah.
Okay, fine. So we will start with the session 1, where I would like to invite the chairpersons for this session, Dr. Kinjal Shah. She's a consultant obstetrician and gynecologist at Bhatia, Saifi and Wokard and Rukshmani Lying in Hospital, Secretary of the Mumbai Menopause Society. Also accompanying her would be Dr. Nidhi Shah Gandhi. Can I have her CV? Yeah. She's a consultant at Jaslok Hospital, and she has a clinic at Hughes Road, director, and she is a treasurer of the AMWI Mumbai branch. Her special field of interest is colposcopy, and she's done her fellowship in colposcopy. Dr. Nidhi and Dr. Kinjal, kindly take over this session, and please introduce the speakers.
Yeah, thank you, Dr. Priya, for the invitation. And without further delay, on the second day, we would like to start with the Parag consultant, OBGYN at Pune, PG teacher and unit head at the Kamla Nehru Hospital. Sir is the chairperson-elect ICOG 2024. And sir, today is going to speak on genitourinary syndrome. So I welcome Dr. Parag, sir.
Yeah, thank you, Kinjal.
Yes.
Good afternoon. I bring greetings from ICOG, and it's indeed a pleasure to be part of the 3-day certification course on menopause. In next 15 minutes, I'm going to talk about something which really bothers so many women, but they don't speak about it, and that's genitourinary syndrome of menopause. Genitourinary syndrome of menopause describes the symptoms and signs which result from the deficiency of the estrogen. We know that the estrogen deficiency has an impact on the urogenital tract and vulvovaginal atrophy, which was in fact the term used earlier, now is considered as a component of genitourinary syndrome of menopause. Why it is important to talk about it? Because it has a negative impact on the women's life. There are adverse effects on the sexual intimacy. Women start feeling less sexual. All in all, their quality of life goes down. We know that estrogen receptors are present as far as the genitourinary tract is concerned in the vagina, in the urethra, bladder trigone, and even pelvic floor. And the deficiency of estrogen does have a bigger impact, especially on the vagina, where there is loss of folds, there's loss of inner lining, and even glandular function. The histological changes also are very much evident, and many a times there are more of inflammatory exudate and more paravasal cells in the vaginal smear. When we talk about the symptoms, we could divide them into vaginal symptoms and the urinary symptoms. So women may present to us with vaginal dryness, with burning, pruritus, dyspareunia, and prolapse. And there could be urinary symptoms like urgency, frequency, dysuria, urinary tract infection, and especially the repeated urinary tract infections. Some of them may come to us with incontinence or even voiding difficulties. So we know that as the age increases, these problems are going to rise. And as compared to younger women, obviously, older women are going to face problems related to the sexuality, and they do complain a lot about superficial dyspareunia. How much is the prevalence of vaginal atrophy? It is noted that almost 40% of postmenopausal women experience vaginal atrophy, but the sad part is only 25% of them seek medical assistance. So it is also important for us healthcare professionals to talk about it, because many a times we are not asking them enough questions to understand the problem they are suffering from. So we must initiate the discussion about vaginal dryness. The patient may be reluctant, but then you need to take her into confidence and talk about the sexual issues or the relationship issues which may present as vaginal discomfort. Assessment of the patient is very, very important. So we must ask her, is she using certain medication? There could be some which may cause vaginal dryness by itself. Physical examination is important, and the examination should include a visual external inspection, a gentle speculum examination, and bimanual pelvic examination. And we must use this opportunity of examination to talk about the genitals, because many a times women of that particular age group are ignorant about the anatomy, and we must talk to them about it, because especially when we are giving them local therapies, they should know where they are supposed to apply these creams. So typically, examination will reveal that there is narrowing of introitus, there is loss of rugosity, the vagina is friable, there could be petechiae. We must rule out atrophic vaginitis, and we should also look for associated urinary tract infection. Of course, we need to differentiate it from vaginitis. We should differentiate it from other conditions like lichen sclerosis and other dermatopathologies. Coming to the treatment has to be based on two principles. First is a restoration of urogenital physiology, and secondly, very importantly, alleviation of symptoms, because she's going to come to you with various symptoms which are bothering her and which are in fact worsening her quality of life. There are certain non-pharmacological strategies one can think about, which includes education. We must educate the woman about the potential vulvar and vaginal changes which are associated with menopause, and especially because of low estrogen level. And we also should talk to them about counseling and sex therapy, where mindfulness exercises and cognitive behavioral therapy may be of certain help. There are vibrators or dilators available which women can use, and they can be more comfortable with their own genital system. And pelvic floor physical therapy is something which is important at that particular age in order to ensure that the pelvic muscle floor has a better strength. Local lidocaine also has been tried by some researchers. So 4% aqueous lidocaine was found to be better than saline, almost in 88% women. And then this is something which was published way back in 2015, but it does appear to be important therapy, especially if the pain is or dyspareunia is the presenting complaint. So women can certainly use local lidocaine during intercourse in order to have a painless intercourse, which is because of the genitourinary syndrome of menopause. Coming to the treatment of vaginal atrophy, and vaginal moisturizers can be of great help. They can primarily be used to relieve the vaginal dryness, especially during the intercourse, but they do not provide a long-term solution. And this is something which has to be counseled to the women. So the mainstay of therapy is local or topical estrogen, which appears to be the logical treatment. We know that it is available in various forms, but most of us are using the creams or tablets. Systemic estrogen also are considered to be the useful treatment for genitourinary syndrome of menopause, but this is something which has to be taken with a pinch of salt, because even after oral menopausal hormone therapy, there may not be great relief in the symptoms of vulvovaginal atrophy. There are certain concerns with systemic MHT like endometrial cancer, thromboembolism, stroke, or even breast cancer, etc. Though we have to counsel our patients and reassure them that these are conditions which are rather rare. So we should be talking more about the local estrogen therapies. Again, there would be certain concerns in the woman's mind about its safety, about the duration of treatment, and the effect on other tissues. So when we talk about the right prescription for urogenital symptoms in menopause, it is the vaginal estriol succinate cream, 0.5 milligrams, or we can even consider equine estrogen cream or tablets. And this has to be applied to bi-weekly. It should be applied daily for 2 weeks and followed by bi-weekly application for about 6 to 12 weeks. There are studies where the same treatment has been continued for a span of almost a year. Lactic acid wash can also be an additional prescription. Mind well, there was a time when we used to monitor the endometrial thickness routinely when we prescribed vaginal creams, but the evidence now says that it is not required. What are the indications for vaginal estrogen therapy in postmenopausal women? Women who come to us especially with vaginal symptoms, those who come to us with recurrent urinary tract infections, overactive bladder, or even before posting them for a vaginal surgery, we can consider a local therapy pre-operatively at least 2 weeks before the surgery, and it can be continued even later in the post-operative period. And of course, where we cannot see this squamocolumnar junction, we can give them a short course of therapy and then think of taking a pap smear. Of course, this is something which is not a common occurrence at that age. What are the advantages and disadvantages? We know that local therapy will not, it avoids the enterohepatic circulation. There's no endometrial stimulation. We are not adding progesterone, or we are not giving any systemic side effects. So the effects are essentially local. So it is generally acceptable even following estrogen-dependent cancers. Of course, you need good counseling for that, and mode of administration has to be explained to the patient because she may not be very comfortable using a preparation vaginally. So these are the preparations that are available. As I mentioned earlier, we do consider the creams. Ospemifene is a third generation, some unfortunately not available in our country currently. It is approved for dyspareunia. So it has an estrogen agonist effect on vagina, and it does not have any effect on the breast, on the endometrium. It helps BMD in the bones. The dose is 60 milligrams per day per orally, but ospemifene, which is an oral SERM, by itself can produce hot flushes, and we have to keep DVT in mind. So to conclude, treatment of genitourinary syndrome of menopause should be started early and before irrevocable atrophic changes have occurred. The treatment needs to be continued to maintain the benefit. All local estrogen preparations are effective, and patient preference will usually determine the treatment used. Delay in starting local treatment will certainly reduce degree of response. Initial loading dose to stimulate receptors followed by a low maintenance dose once or twice a week is the key. Following gynecological cancers, the use of local estrogen may not be contraindicated, but we need to talk about the risk and benefit to the woman. And use of local estrogen therapy in women on tamoxifen and aromatase inhibitors needs careful counseling and discussion even with the oncology team. So these are the recommendations of the NAMS, that is North American Menopause Society. They recommend that we should educate our women, screen all women for genitourinary syndrome of menopause. The first line therapy would include non-hormonal therapy, non-hormonal lubricants, which are to be used during sexual activity, and long-acting vaginal moisturizer. Women who have moderate to severe symptoms who do not respond to lubricants and moisturizers, here we can consider DHA, ospemifene, or even low-dose vaginal estrogen therapy. Although the product's labeling for low-dose vaginal estrogen therapy notes risks associated with systemic HT, which includes CHD, stroke, VT, etc., these risks are highly unlikely given minimal systemic absorption and reassuring findings from clinical trials and observational studies. So use of progesterone is something which is not recommended when we are using vaginal estrogen therapy, and furthermore, the NAMS suggests that routine endometrial surveillance is not recommended. Spotting or bleeding in a postmenopausal woman requires thorough evaluation that energy-based therapies, including vaginal lasers, radiofrequency devices, etc. We are not sure about their usage, but then these options are also available. And therapy for GSM should be continued with appropriate clinical follow-up as long as bothersome symptoms are present. So thank you very much. And once again, thank you to the office bearers of ICOG for having me here. Thank you.
Thank you, sir, for a very crisp and like a proper on-point presentation. Like it's very important, as you correctly said, that awareness and education is very important. Thank you, sir.
Yeah, thank you.
Dr. Nidhi, are you there? Okay, so yeah. Nidhi, you'll introduce the next speaker? Yeah.
Yes, I will. Yeah, thank you, Kinjal. Can I have the CV, please? Priya?
Tech team, can you put, yeah, she's put it. Archana Dwivedi, madams.
Yeah, so our next speaker for today is Dr. Archana Dwivedi. She's the president of BOGS 2425, past president of BOGS, secretary.
Thank you for that. I'm happy to be with everybody and it's a good platform for me. So I think we'll just, for the want of time, as Dr. Parag sir has finished very well. So should I start if you...
Sure, ma'am. The platform is all yours. Yeah, thank you, ma'am.
Thank you so much. So I think my slides have stopped moving. So are they moving, Pam? Just tell me, they are moving. The slides are moving, right?
Yes, they are moving, ma'am.
So thank you for the opportunity to talk about the cardiovascular health in the menopause, which is actually the very upcoming thing, I would say, because majority of the women who are falling into this category from menarche to the menopause, the limited cumulative effect, if you see, it's like reproductive factors on heart cardiovascular disease is currently leading cause of death among the women, accounting for more than 50% cases, out of which 20% are attributed to the ischemic heart disease and 13% to the... So if I have to roughly classify that heart disease, which is associated with menopause, as you can see here, that in this diagram, the pre-menopause and the predisposing risk factors, ovarian aging, chronological aging, all go together, making the women more susceptible to heart failure, atrial fibrillation, and CHD, which are the main leading cause of cardiac problems as the age advances. So menopause strikes average Indian age is 46 to 47 years, and about 25% years of her life, she silently suffers an estrogen deficiency. And this is the right time when we should act, because as the age advances, there is 2% increased risk in the cardiac heart problems and cardiac diseases. Menopause itself is a risk on the female, and to add on it, the metabolic syndrome, increased blood pressure, reduced glucose tolerance, and endothelial dysfunction with the advancing age cause accumulated effect augmentation in the CVD risk. So the challenges for us remain that to perceive it properly, social, clinical, surgical, and outcomes and special consideration should be taken into account whenever discussing a menopausal lady, because the cardiovascular health the problem becomes later than the men because of the production of estrogen in the reproductive phase of their life. But once they enter the menopause, the risk is going to increase, and estrogen's protective effect against the heart disease, once lost, and rightly, if we don't administer the MHT, the risk of CVD increases in most of the cases. And here, as you can see, that the major threat, the greatest perception of the female has that about the cancer, not about the heart disease. But when you see the awareness and the studies which have been conducted, it is actually at par with the cancer if we talk about the heart disease in women. So the cardiovascular disease is number one cause of death in women. Yes, it is true, because every year heart disease kills the women more than men, and 38% of women die within a year of suffering a heart attack compared to 25% of the men. So as I was discussing, why estrogen protects because of the angiogenesis, vasodilatation, reduced oxidative stress, inflammation, vasoconstriction, and fibrosis of the heart muscles and the internal changes into the arterial milieu. And these mechanisms lead to limit the heart remodeling and reduce the heart hypertrophy. But as the cardiovascular changes, as the menopause sets in, this decreased estrogen and cardiometabolic changes increase the CVD risk because of increase in the the protection of myocardial pro-survival antioxidative stress mechanism that is decreased. So there is increase in the infarct size, and the fibrosis, which was protected, again gets lost. Vasculature is also affected because of the increased angiogenesis, and antioxidant property is again lost with the decrease in the estrogen content. So the cell survival rate actually decreases. So this ovarian and chronological aging, if come together, these are the certain risk factors where the physical activity, menopause, alcohol intake, pregnancy, multiparity, valvular heart disease in past, systolic hypertension, obesity, and coronary heart disease history, sleep apnea, which is very commonly affecting the women nowadays, smoking, diabetes, and thyroid diseases all have a cumulative effect to the endothelial dysfunction, causing myocardial hypertrophy. Ventricular remodeling is getting slowed. So this is what increases the risk of heart failure in the women as she advances towards the menopause. So if I have to enumerate negative alterations in lipid profile, obesity, diabetes, smoking, hypertension, lack of physical activity, pregnancy outcomes affected by preeclampsia and comorbid conditions like gestational diabetes, premature menopause, PCOS, and systemic autoimmune disorders, history of breast cancer and DVT, venous thromboembolism in the patient itself increase the risk. So now we have to change our perceptions towards the women, because heart disease affects women in every age now because of the increased awareness and increased checkup. We know that they are the males in the red and white and the females. Females are no shorter considering the age, and even before the age also, the heart diseases are as common as in men. And menopause transition contributes to an increased risk of heart disease. So this is a very important thing we should have to keep in mind, because many studies have been conducted where women with early onset of menopause, that is less than 45 years, have significantly higher risk of overall having the cardiac diseases. CVD risk factors have been established in various studies and meta-analysis which have been done. And we need to be very careful by dealing with this patient, because this is the very important study which was conducted where 3, 5, 6, 8 heart failure events compared with women with later onset of menopause. So I think we should give an ear to our patients whenever they come to us, because there are something specific characteristics of female ischemic heart disease and its tendency to be missed out. Because women with coronary heart disease are more susceptible because the coronary artery diameter is less, small cardiac mass, and onset is 7 to 10 years later than when the menopause starts, and lower atheroma burden, less calcified and tender plaques which get misdiagnosed or are missed to be diagnosed, more diffuse and less obstructive thing is seen, and progress is comparable in both the sexes. Here, if I consider the acute coronary artery syndrome, 25% of all the ACS occur before the age of 65 years, and more than 2 female sex-specific RF high risk factors are there when we focus on the middle-aged women, where there is endothelial dysfunction and also the comorbid conditions like diabetes and hypertension. Obesity all go hand in hand, and also we should not forget the genetic factors which play an important role. So if I have to compare, the women more than 60, less than 60 years have got a higher mortality from acute coronary artery syndrome. And according to the WISE study, women are more likely to have microvessel disease, which do not show up in the angiogram. Hence, the diagnosis is very difficult, and under treatment and poorer outcomes are found compared to the men. The typical symptoms also differ, because chest discomfort or pain, symptoms which are common in women are pain in neck, jaw, shoulder, upper back, or abdomen, which usually get unnoticed, nausea, vomiting, sweating, anxiety, abdominal pain, heartburn, dizziness, lightheadedness, unusual unexplained fatigue are the usual presentation when we compare to the general presentation like stomach pain, shortness of breath, sweating, anxiety, nausea, vomiting in the men. So again, I have to talk a little bit about the gender bias, because women is always neglected. Even when she's a small child, replacement, the heart diseases are not being taken so seriously. because people think that they are not old enough to be at risk and they are too busy to make the changes in their lives. And the stress is a very important factor, which is the underlying cause of cardiovascular diseases in the women. Nutritional status, anemia, osteoporosis, poor exercise tolerance, obesity, and psychological issue are the add-on problems. Henceforth, predisposing women more to the mortality if I compare to the men data. And women are less likely to survive coronary artery bypass surgeries also and experience complications more after angioplasty. And they are more likely to suffer from irregular heartbeats or arrhythmias which are life-threatening. Family is having a preference to the male child, and congenital heart disease treatments usually go undiagnosed still in our OPD because of the delayed treatment of adolescent girls who wait till marriage to the issue be solved. The choice of prosthetic heart valves are very much influenced, predisposing them to the more important predisposing factors and complications into the reproductive career as well. The gender discrepancy, if I have to discuss in the Indian scenario, 30% of angioplasty, stent and bypass surgery, 23% of implantable defibrillators, 25% open heart surgery, out of which women comprise only 25% of participants in all heart-related studies, research studies as well. And deaths due to cardiac diseases are more unreported. So if you have to see the clinical picture, there is chest discomfort, nausea, sweating, lightheadedness, upper body discomfort, which are missed in angiograms, and depression, smoking, diabetes, they all are the masking things, pregnancy, hormonal changes during the menopause. There's a masking effect if you compare the symptoms. Henceforth, the diagnosis becomes a little late or sometimes undiagnosed, because women 35 to 44 have always been thought to have as being very low risk and by the traditional standards. And now we know that it isn't always the truth. Because the issue of having a poor quality of sternum, poor quality of conduits, and short stature, small size peripheral arteries, wound healing is delayed. Female sex as a marker of high Euro scores also when we do the preoperative scores as per the American standards. And here the hormonal changes are the interplay in between, where the childbearing age, starting of menstruation, pregnancy, miscarriages, perimenopause or menopause, in total the climacteric phase, where we need to consider the masking symptoms and have to report the women as early as possible. So what are the markers which we have to look into when the patient comes for the screening? Do her lipoprotein status, because LDL, VLDL, and HDL are the markers, where HDL is considered as scavengers of cholesterol, 50% of protein. High HDL is always a good score for the cardiac risk. And apolipoproteins A and B should be well evaluated, because dyslipidemia, hyperhomocysteine, C-reactive proteins are likely to increase the infection, and they affect the arterial diseases more compared to the venous diseases. So if I have to assess a patient for the risk, her past history is very important. Pregnancy history is very important. Her family history is equally important, and biomarkers and lab, the waist ratio, weight, BMI, BP, lipids, glucose have to be put into account, and pooled a CVD risk has to be calculated. How do we go about in an Indian scenario? We have got a World Health Organization, an Indian, sorry, for this cup. The charts are useful for stratifying risk for people with blood pressure more than 100 or blood cholesterol more than 8 millimoles per liter, or uncomplicated diabetes with or without treatment. So an individual is classified as high, medium, or low risk over 10 years. In this type of classification, the 10-year risk is calculated, but it has got its own limitation, where the family history of POI or premature coronary heart disease, first degree relatives have not been taken into account. Also, the lipid levels, triglyceride levels, HDL have not been taken into account. C-reactive protein, an important marker, and sedentary lifestyle has not been taken into account. So it may be an underestimation of a severe risk. So make it more patient friendly. CRD or Southeast Asia region, CRD, 10-year prediction chart was used in India, where we calculate gender, age, systolic blood pressure, and smoking status, and 4 sets each for female and male, 2 for the presence and absence of diabetes mellitus, and 2 with or without the cholesterol readings. Further, we have got Framingham's risk calculator, where the scores are calculated based upon the sex, age, whether she's a smoker or not, blood pressure, statistics, systolic and diastolic, and what type of treatment she's undergoing, total cholesterol levels. The scores are giving like this, and total points -1. Risk of heart disease in 10 years is predictable by something less than 1%. So this is a study which is easily available online. Apps are available and very important to calculate the outcome. So if I have to do a have to approach a patient with where we have to calculate the CVD and menopausal symptoms both. The comprehensive evaluation which is very important to identify, evaluate the current CVD risk factors and assess the menopausal symptoms, and identify factors which are affecting the MHT choice. MHT stands for menopause hormone therapy, because we need to optimize, we need to treat the menopausal symptoms and persisting difficult vasomotor symptoms. Along with that, the age, the where which we are starting the MHT is very important, because we need to consider safer options like transdermal estrogen patches, which are easily available in the patients who are without hysterectomy, and lowest doses for the shortest time should be our agenda. The premise thinking timing of hypothesis denotes that poses that the effect of menopause, MHT, atherosclerosis, and clinical events are dependent on the MHT is initiated. When early initiation is always better, because we are going to prevent the changes in the arteries of the heart, and plaque formation is a little bit less because of the antioxidant effect of the estrogen, and the beneficial effect is very, very important, because when we start later in the age, say within 10 years of menopause, it's the best time for the prevention. The studies say that directly it does not contribute to the prevention of the CVD, but early MHT initiation will help for retaining the lumen of the artery and preventing the atherosclerosis. That is the way it acts. And here you can see that early initiation, the arteries from the angiogenesis, the mural thrombus, everything is prevented. But at the age when you start late, it can be harmful also. So early initiation is the keynote where we prevent formation of necrotic core plaque and help the patients most. Just few minutes. So the MHT starts.
Ma'am, your time is up.
Yeah, I could get it. Just give me 1 minute more. And it is safer to use for 5 years. If I have to say all these slides, one thing is very, very clear, that cardiac mortality risk decreased within the 1 year of minimum MHT, but increased on its discontinuation. There are various options which are available, and we can choose the MHT wisely from the oral and transdermal nowadays, because aspirin is also available, statins are also available. We are giving folic acid. We are giving anti-stress treatment, like engaging the patients into the regular exercise, as in to quit smoking, get plenty of sleep, and talk to their doctors whenever the unusual symptoms are there. Eating healthy is very, very important. An important highlight is using the MHT, that is the menopause hormone therapy, and keeping the comorbid conditions in control. BMI reduced to less than 25 and waist size less than 35 is a good thing. Keeping lipids in check is a good thing to prevent the cardiac diseases. And intermediate risk and all can be calculated. Goals are to set early MHT in the patients who are very high risk, having a history. This is the combo drugs which can be given to treat the patients to prevent the CVD. So it is just benefits exceeds the risk, and the risk can be more when we start after later age, that is beyond 55 to 60 years. So premature ovarian insufficiency patient MHT is mandatory till the natural age of menopause to prevent the cardiac complications. Last few slides where I want to push into the 10 commandments of physical health. Eat food rich in calcium, vitamin D, maintain moderate weight, eat lots of fruits and vegetables, avoid the trigger fruits, exercise regularly. More fruits rich in phytoestrogens, drinking water is good, refined sugar and processed food should be avoided. Don't skip the meals and eat protein rich food, dance, sing, meditate, socialize, and be more stress-free. Do whatever can be done to keep yourself stress-free, because estrogen is a product. I'm sorry for my this chikungunya status. So healthy lifestyle and initiation of the MHT at the right time is a tender loving care which we can offer to our patient, because aim should be fit at 40, fancy at 50, strong at 60, sexy at 70, independent at 80, and naughty at 19, and healthy at 100, because we are having increased life expectancy in the patients, and that is what we aim. These beautiful ladies living in this era together with us. And this is one campaign which got into my eyes when I was surfing the Facebook, because red dress campaign, where you need to understand that heart disease is the silent killer of the women, and women are important in the society. So 1 in 3 women died of heart disease. We need to have a red dress day and to prevent the complications of CVD. Thank you for the patient hearing. I think exceeded a little bit, and sorry for the my throat. Hope I could just stick with the topic. Thank you.
Thank you, Dr. Archana. It was a very informative talk. We'll move on to the next speaker. Kinjal, will you take it?
Yeah. So I would like to introduce our next speaker, that is Dr. Geeta Balsarkar, madam. CV, please. Madam is the past president of Mumbai Menopause Society and the secretary of the Mumbai Obstetrics and Gynaec Society. And madam is going to speak on sarcopenia and bone health, the crosstalk.
Thank you, Kinjal, for that kind introduction. I'm not going to talk much about bone health because the topic that is given to me is sarcopenia, and I'm going to use this particular slide which has got both about sarcopenia and crosstalk. Tell me when my time is over so that I will just stop with sarcopenia and not cross over to bone health. Somebody else is talking on osteoporosis. So we all must know that sarcopenia and bone health, they are associated with each other. It is called as musculoskeletal disorders. So they are both combined. And according to 2011 census statement, if we see the total population, women are roughly 48%, that is nearing 50% of the total population. And life expectancy at birth for females is projected to be about 72 years. This means that all the gynecologists will have to become menopausal specialist, and we'll have to treat a lot of postmenopausal women. So with growing elderly population and increasing longevity in Indian women, postmenopausal musculoskeletal disorder, it is emerging as a major public health issues, and all the gynecologists should be trained to screen patients for these musculoskeletal disorders. So if we see what does menopause do, we all know that the peak age of bone mass is around 30 years, and after 30 years there is no increase in bone mass, it only decreases. The menopause transition leads to changes in physiological function, one by itself because of increasing age, which is there in the male population also, but in females decreasing gonadal hormones contribute more to their muscle and bone mass. Therefore, compared to men of the same age, women suffer accelerated loss in the bone mass density, in muscle mass, and most importantly, the muscle strength. So there are things called like modifiable risk factors and non-modifiable risk factors. Modifiable risk factors means these are there in our hands. If we change that particular habit, it can be modified, like alcohol intake, smoking, low body mass index, calcium intake, vitamin D deficiency, insufficient physical activity, and frequent falls. All these can be definitely prevented by taking proper steps. Non-modifiable risk factors are gender, your age, family history of fractures, family history of frailty, family history of sarcopenia, any previous fractures, race, ethnicity, onset of menopause, history of hysterectomy. All these are non-modifiable risk factors. So seeing how many modifiable risk factors she has and how many non-modifiable risk factors she has, we can predict the onset of sarcopenia. So what are the factors affecting musculoskeletal health? If you see the diet, improved musculoskeletal health is seen with regular consumption of soya, with almonds, fish, fruits, milk, calcium supplementation, vitamin D, and proteins. And negative influence on the osteoporosis and sarcopenia is late menarche, when it occurs after 14 or about 16 years, early menopause or premature menopause, postmenopausal for more than 10 to 15 years, and multiparity. So if she has had more than 3 pregnancies, she is at a risk for bad musculoskeletal health. Aging by itself also affects both muscle mass as well as the bone mass. So it causes sarcopenia, as well as osteoporosis. When there is reduction in muscle mass, it impairs the muscle strength and impaired balance. And if there is reduction in bone strength as well, both of which put together makes a patient prone for fracture. Now, common musculoskeletal disorders among postmenopausal women are osteoporosis, wherein there is a reduction in bone mass as well as bone strength, and osteoarthritis, wherein the cartilages and the joints are affected, and sarcopenia, which is muscle mass is reduced as well as the muscle strength is reduced. All of these leads to frailty, they leads to fall, and then eventually fracture. So if you see sarcopenia, it has got lot of reasons. It could be age related, which is a primary sarcopenia that we see because of reduction on sex hormones, because of apoptosis, because of mitochondrial dysfunction. Then we can see sarcopenia because of disuse, because of immobility, because of reduced physical activity, and zero gravity is what we are seeing in the astronauts who is stuck in the outside space. If you are seen her photo about a month back, and if you see her photo now, you can see how much muscle mass she has lost. So even zero gravity causes sarcopenia. Inadequate nutrition and malabsorption and neurodegenerative diseases like motor neuron loss, cachexia, and all endocrine dysfunctions. Primary among these is abnormal thyroid functions, insulin resistance, diabetes, and even intake of corticosteroids. All these lead to sarcopenia over a period of time. So if you see this particular picture, if you know this is what is a normal muscle, and then on the other right hand side is a atrophied muscle, we can see what is the effect of the atrophy on these muscles. So sarcopenia is defined as loss of muscle mass and function that is also associated with aging. Cachexia is weight loss due to some underlying illness. Sarcopenia does not necessarily have some severe illness underlying it. Both are muscle wasting disorders of particular relevance in the aging population, but they go largely unrecognized. By year 2050, individuals of over 65 years will comprise 20% of US population. In India, there will be about 30% of the Indian population, and more than 4.3% will be over 85 years of age. This is associated with increased dependence, frailty, and mortality. Then there is also a osteoporosis, that is sarcopenia associated with osteoporosis, and sarco-obesity, where there is sarcopenia, but the fat content is relatively much more, and frailty. These are all the terms and definitions that we'll be talking in some time. So if we see the definition, the life course model of sarcopenia, operational definition of sarcopenia can either be based on measurement of muscle mass alone, or combining the measures of muscle mass, strength, and physical performance. Around the fourth decade of life, the decline occurs in the muscle mass strength, and this accelerates with advancing age. So if we see that as the age advances, the range of mass and strength in individuals that goes down, and environmental changes can further lower this disability threshold. So they need rehabilitation, and we need to ensure that the quality of life is maintained. There is primary sarcopenia, which is age-related sarcopenia, no other evidence except the age, and secondary sarcopenia, which is related to the activity. That is, it can recur from bed rest, it can recur from sedentary lifestyle, deconditioning, and zero gravity conditions. So the EWGSOP conceptual stages of sarcopenia can be divided into pre-sarcopenia, sarcopenia, and severe sarcopenia. In pre-sarcopenia, only the muscle mass is reduced, but the muscle strength and performance is retained. In sarcopenia, the muscle mass and muscle strength are reduced. The performance could be retained or it could be reduced. And in severe sarcopenia, there is reduction in muscle mass, muscle strength, as well as the performance. So the severe sarcopenia reflects the severity of condition and helps in selecting and treatment and setting the goals, recovery goals, and it supports the research studies. So this is what we had already seen, the pre-sarcopenia, sarcopenia, and the severe sarcopenia. Now, if you see this particular muscle, this 1A and 1B muscle, it's a 1A is a compact muscle mass in a 19-year-old individual, and B is it's an 86-year-old sarcopenic individual. You can see how there is a reduction in the muscle mass, and along with the reduction in the muscle mass, there is a reduction in the performance as well. So sarcopenia is characterized by atrophy of muscle fibers, especially the type 2 fibers, which are responsible for fast motion, and also by decreased number of motor units and accumulation of fat within the muscle. So these two things together form sarcopenia, decreased number of motor units as well as accumulation of fat within the muscle. So this we have already seen the various reasons for sarcopenia, and further understanding we need to know that there are complex interdependent pathophysiological mechanisms like aging, there is physical inactivity, there is neuromuscular compromise, resistant to postprandial anabolism, insulin resistance, lipotoxicity, endocrine factors, oxidative stress, mitochondrial dysfunction, inflammation. All of these are present in an individual in varying proportions, and they cause varying degrees of sarcopenia. So if we see that it could be primarily genetic, further immobility, other mechanisms, endocrine, muscle fiber atrophy, neurodegenerative diseases, decreased protein synthesis, and nutrition. These are all in all responsible for sarcopenia with reduced muscle mass and muscle strength. So the muscle mass protein pathways for synthesis and degeneration, they are there, the protein synthesis as well as the degradation. That's a balance. What is the muscle mass? It is a balance between the new protein synthesis as well as the protein degradation. So we can see what all affects the protein synthesis: insulin, being a diabetic, exercise, testosterone, all these affects the protein synthesis, whereas the protein degradation is affected by inactivity, it is affected by inflammation, it is accompanied by atrophy related genes and all this. So the balance between protein synthesis and protein degradation is responsible for whatever muscle mass is there in a particular individual. Now, bone muscle crosstalk is there continuously. If the bone is osteoporotic, the muscle will be sarcopenic. If the muscle is sarcopenic, the bone will be osteoporotic. So in this particular slide, you can see how physical activity is responsible for the strength and performance, which is responsible for the muscle mass and sarcopenia, and also responsible for the bone strength and osteoporosis. So nowadays they are coining a term called osteosarcopenia. So it is not only sarcopenia, it is muscle and the bone together. So it is called as osteosarcopenia, which predicts the fracture risk, the fall fracture, and eventually the mortality. So in the bone and the muscle, there is always a crosstalk going on, wherein if there is increasing BMD, it will cause increase in muscle strength and decrease the fracture risk and increase the muscle mass and protect the muscle. So what are the hormones that are responsible for that? There is testosterone, there is SERMs, there is denosumab, there is anti-myostatin. These are all responsible for the crosstalk between the bone and the muscle. Who should be screened for sarcopenia? Any patient who is bedbound, who is non-ambulatory, unable to rise from a sitting position unassisted, with history of weight loss more than 5%, with any reported decline in the muscle function and strength, recurrent falls after hospitalization, with any comorbidities like diabetes, cardiac failure, chronic kidney disease, obstructive pulmonary disease, rheumatoid arthritis, and when the gait speed is less than 0.8 meters per second over 4 minutes, all these patients should be screened for sarcopenia. What are the diagnostic tests? Muscle mass atrophy, bioimpedance analysis, dual energy X-ray absorptiometry, muscle strength, hand grip strength using dynamometer, and muscle function assessment. These are all the tests for sarcopenia. I won't go into much detail, but then we can do other tests for muscle mass like CT, MRI, DEXA, bioimpedance analysis. For muscle strength, the hand grip strength, the knee flexion, and the physical performance like gait speed, time get up and go test, stair climb power test. These are all possible, and a lot of it is in research, but in clinical practice also some of them can be used to diagnose the degree of sarcopenia. So this is in detail about the bioimpedance analysis. It's a predicted skeletal muscle mass equation is there based on the 2SD below the mean of young adults in the study, in which they have classified men as severe sarcopenia as less than 8.5 kg per meter square, moderate is 8.5 to 10, and normal muscle is more than 10. Whereas for women, the statistics are different. Severe sarcopenia is less than 5, 5.76 to 6.75 is moderate, and more than 6 is normal for women. Then muscle mass anthropometry not recommended as it's very variable, which includes the calf circumference, the mid upper arm circumference, and the DEXA, which muscle strength, hand grip strength, the muscle function, all these can be studied. Now, if we see, it's a price primary consequence of sarcopenia is a physical function impairment. There is weak muscle strength, there is slow gait speed, there is poor balance. On one side is sarcopenia, on the other side is frailty, deficits, accumulation, fatigue, sedentary behavior, weight loss. Frailty also causes cognitive impairment and social isolation. So all in all, sarcopenia, when it progresses, it will lead to frailty. So there is something that is now come out there. This is called as a locomotor syndrome conceptual, diagram or a design, wherein they say everything related to locomotion, that is the bone which suffers from osteoporosis and fracture, the joint cartilage and intervertebral disc causes osteoporosis, osteoarthritis, the muscle and nerve will cause nerve disorder and sarcopenia. All this will cause pain during movement. There will be joint mobility, then there will be muscle strength. There will be pain, mobility, muscle strength and balance will be lost. And this will cause further reduction in mobility. When this causes further reduction in mobility, there will be limitation of daily living activities. There will be restriction on social participation and need for long-term care. India is moving like the US towards the long-term care which is needed for the elderly in the form of, hospital or some other form of daily care. So the sarcopenia, wherein the musculoskeletal domain and osteoporosis, when it progresses, it forms physical frailty and it causes non-physical domain. So what is the phenotypic?
Ma'am, your time is up.
Yeah. So if any patient comes with unintended weight loss, don't be too happy that she's lost obesity. If there is muscle weakness, if she walks very slow, if there is low physical activity and she looks very exhausted, think about sarcopenia. So all in all, we have to remember that sarcopenia and osteosarcopenic obesity, wherein there is increased mass and fat infiltration and redistribution, all these increase her chance of having a fall, and then it eventually leads to a lot of other problems because of that. So with that, I thank you for a very patient hearing. Thank you.
Thank you, Geeta madam, for the lovely talk and letting us know about how to diagnose sarcopenia. On behalf of Nidhi and myself, I would like to thank the whole ICOG team for giving us the opportunity. Back to Dr. Priya. Thank you.
Thank you.
Thanks Nidhi and Kinjal for sharing an excellent talk by all the speakers. Now I would hand over to the co-MOC, Dr. Prerna, to take over session 2.
Prerna needs to be unmuted. Make a co-host. Huh?
Yeah, thank you. Wishing you all a very good evening, and I'm immensely honored I am to be a part of this wonderful scientific session today. And we once again welcome you to the FOGSI ICOG certificate course in menopause. And we have a string of stalwarts associated with us today, and we move on to the session 2. And for this, we invite Dr. Ganpat Sawant sir to chair the session. He's a former HOD and Professor D.Y. Patil Medical College, Navi Mumbai, and Director of Noble Plus Hospital, Ghatkapur, Mumbai. We are so very honored, sir, to have you amongst us. Second chairperson is Dr. Rachna Dalmia. Dr. Rachna is one known face when it comes to ONG. Welcome, ma'am. We are so honored to have you amongst us. Our first speaker is Dr. Charmila, ma'am, and I request our chairperson to kindly introduce Charmila, ma'am, for her talk. Dr. Sawant, sir. Are you there?
I think both of them are not there. I'll just start. It's okay, just stop.
Dr. Charmila needs no introduction. She is a very kind-hearted person. Let me tell you first this, and a friend, a philosopher, and my guide as always. And I have been so very fond of her for years together in FOGSI now. She's a Vice President FOGSI 2024, and a series of awards and credentials to her credit, which will take an entire day for me to summarize. Welcome you, ma'am, for this prestigious deliberation. The dais is all yours, ma'am.
Thank you so much, Prerna, for that very kind as well as loving introduction. It's my honor to be a part of the certificate course on menopause. So my talk is going to be on metabolic health in menopause. And we have to remember metabolism affects different people differently. There's an actress, an American actress, who said in 2007, I put on 20 pounds when I was 40 years of age. I always thought that I had a perfect metabolism, but my metabolism betrayed me as it does most of the people, except a very rare few will always be thin. So it holds true for many of women because not all will be destined to be thin. We will suffer from some form of the metabolic syndrome. But when there's a definition for metabolic syndrome, and there are so many guidelines for it, but the WHO classification is usually taken. And it says you need to have insulin resistance along with any two of the following criteria. And that is an abdominal or central obesity with a waist to hip ratio of more than 0.85 in women, or a body mass index more than 30. Can be hypertriglyceridemia, which is more than 150. Can be low high density lipoprotein. In women, it's less than 39. A high blood pressure, or there's a documented use of antihypertensive therapy. There's a high fasting glucose, which can be impaired glucose tolerance, impaired fasting glucose, insulin resistance, or diabetes. Or microalbuminuria, which is urine albumin to creatine ratio of 30 milligram per gram. So you need to have insulin resistance along with any two of the criteria to tell that the person is suffering from metabolic syndrome. There are certain risk factors for metabolic syndrome. Can be obesity, can be a body fat distribution for more of central fat, physical inactivity, excess caloric intake, unhealthy dietary habits. And nowadays, exposure to medications like antipsychotics, a family history of mental disease, socioeconomic factors, and a low vitamin D level can also lead on to development of metabolic syndrome in menopause. There's an increased risk as far as postmenopausal women are concerned. It varies from almost 32 to 42%. That's almost like half of women over the age of 50 when they are postmenopausal can land up with metabolic syndrome. Weight gain in postmenopausal women is the one which usually determines the development of metabolic syndrome. And increase in the central fat mass compared to rest of deposition of fat in the body is actually conducive for development of metabolic syndrome. So that's why the waist hip ratio is very important when you want to identify a lady who's going for metabolic syndrome. And obesity of the abdomen is a predominant condition of metabolic syndrome. It is indication of insulin resistance. That is, the body stores fat in the abdominal wall when there is overeating or there's a reduced physical activity. And it indicates insulin resistance. And insulin resistance, we know it's a pro-inflammatory and a pro-thrombotic condition. And this will be associated with the later risk of developing a frank diabetes mellitus, higher blood pressures, and other chronic conditions. So almost everything starts with central obesity in menopause. And there are certain hormone changes in menopause which seem to which seem to cause the development of metabolic syndrome. And that is the turbulence which is there in the perimenopausal period when menopause starts, and the lifestyle modification that the lady does. And Geeta gave a beautiful talk on sarcopenia. Women tend to become slower as they age, and that actually adds on to development of metabolic syndrome. And there's an abnormal secretion of cytokines when there is a hormonal disturbance, and that will cause dysfunction of the endothelium. And that's why there's an increase in cardiovascular changes and subsequent morbidity and mortality in women. So metabolic syndrome is not innocuous. Once it starts, it will increase the cardiovascular damage in a menopausal person. And in many longitudinal studies, they've identified a predominantly a change from an estrogenic environment to an androgenic environment during the menopausal transition. The ovarian androgen secretion increases due to the stimulation by the increased pituitary gonadotropins, which happen because of the fall in estrogen. So estrogen falls with the depletion of the follicles in the ovary. So when that happens, the pituitary gonadotropins increase in the form of FSH, and that is going to drive the increase in the secretion of androgen from the ovaries. And this androgen is the one which is the reason for central obesity, and then it leads on to metabolic syndrome. And the decrease in estrogen also causes a fall in the sex hormone binding globulin, and that's why you find more of free androgens in the circulation. This bioavailable testosterone will lead to more fat accumulation in the pre-adipocytes of the fat in the viscera. And when the lady has a slower increase in bioavailable testosterone, it will be actually adaptive for her. But when there's a very fast increase in bioavailable testosterone, which can happen as in surgical menopause, will drive metabolic syndrome much quicker. And this Kaita has already talked upon. We have to remember that skeletal muscle is needed for insulin-dependent glucose metabolism. So when there's a loss of skeletal muscle mass, which is called sarcopenia, and usually it happens in menopause, there will be an insulin resistance and the development of metabolic syndrome. This muscle loss will also cause a fat accumulation in the intramuscular area because of the loss of muscle, and that will be replaced by fat. And when that happens, there's an abnormality in muscle contraction, and the lady becomes weaker and she's unable to move. And the factors like oxidative stress, cytokines, which cause inflammation, and the dysfunction of the mitochondria can all be the contributory reasons for sarcopenia. So what happens is, because of the poor muscle power, because of the loss of skeletal muscle, the insulin resistance happens because of that, and then the mobility of the lady becoming slower. So there's a decrease in physical activity because she's unable to do the work she was doing previously. And there will be an increase in obesity because she's not having much of physical activity. And so this condition is labeled as sarcopenic obesity. That is, her muscles are weak, but she's got more of fat tissue. And this reduction in skeletal muscle mass, body weakness, and increase in visceral adiposity will lead on to the development of more of metabolic, becoming a more severe form of metabolic syndrome. And there are some symptom clusters in which can actually cause a higher risk of poor cardiometabolic outcomes of Framingham score and obesity. And these clusters are the stage of menopause that the patient is, the sex hormone levels which she has, sleep disturbances, a history of major depression or presence of symptoms of depression. When they're all present, it's going to add more features to the metabolic syndrome in menopause. The type of menopause also matters for the development of metabolic syndrome, and it becomes very severe in surgical menopause. And when there's an abrupt decline in the estrogen levels after surgery, there will be a associated dysfunction of the endothelium. There will be an increase in atherosclerotic lipoproteins, and there's an increase in lipid oxidation. So all this will cause a very severe form of cardiovascular disease. Moreover, her diabetic status also changes, and it's found that surgically menopause women will have a higher fasting blood glucose and a 2-hour blood glucose level compared to women who attained menopause spontaneously. And time since menopause also matters. There was a study called the Study of Women's Health Across the Nation. And here they found out that the incidence of metabolic syndrome increases gradually between 6 years before the final menstrual period and 6 years after the final menstrual period. And this regardless of age and other known cardiovascular risk factors. And that's why it's very important that the period around the menopause is managed appropriately and adequately. And when there are multiple concurrent moderate to high intensity physical and psychological symptoms in menopause, there will be a higher chance of the person developing early onset diabetes and metabolic syndrome. And how do you manage metabolic syndrome in a menopausal person? It is, when there are risk factors, please remember to monitor her adequately and take out appropriate interventions whenever needed. And that is, you will be evaluating her blood pressures, her waist circumference, her lipid profile, her blood sugars, and adequately you should manage her before she goes on to the full-blown form of the disease. And when this is done, there will be a substantial reduction in the cardiometabolic risk in this crucial period. And the strategies which are useful for the prevention of metabolic syndrome are usually lifestyle modification rather than any drug. And that will be in the form of physical activity and a calorie-controlled diet. Pharmacotherapy should be added whenever needed. Probably bariatric surgery should be thought of. Traditional health practices like yoga can also help. And medicines which are used in other than allopathy can also sometimes help if the patient is put on a calorie-restricted diet. And regarding diet, there are enough studies which say a diet with calorie restrictions has lots of beneficial effect on the components of metabolic syndrome. And in one study by Rodriguez Caro et al., they said the use of high energy refined grains resulted in improvement in fasting blood glucose when there's a reduced intake of refined grains. And when they consume a low-fat diet, it also showed a reduction in diastolic blood pressure and an increase in the HDL level. So it has got a beneficial effect when the diet is just changed to a diet which does not contain refined grains and has a low-fat diet. And regarding the hormonal therapy, which can be tried in metabolic syndrome, remember that even when the patient does not have metabolic syndrome and hormone therapy is given for some other symptom like vasomotor symptom, it is known to decrease abdominal fat. So it will have a beneficial effect in the metabolic syndrome. And also there are studies which show that it can improve the insulin resistance, even though the data is mixed. But remember that the oral form of estrogen can have a small procoagulant effect even in normal postmenopausal women, and that is not observed in transdermal therapy. So when you want to start on hormone therapy, it's better that you go for the transdermal form rather than oral therapy for metabolic syndrome. Remember that oral hormone therapy can cause an increase in leptin and the leptin-adiponectin ratio. It can worsen parameters of insulin resistance. They reduce inflammatory markers except CRP and MMP9, which actually increase. There's a minimal procoagulant effect. Transdermal hormone therapy has got none of these changes which are harmful, and it will reduce all the inflammatory markers, and there's no procoagulant effect. But blood pressure is not affected by any form of hormone therapy in women with metabolic syndrome. And the transdermal therapy is beneficial for reducing many parameters of metabolic syndrome. And the dose is actually 50 microgram twice a week when you want to start on transdermal therapy. Oral hormone therapy, if you want to start, you have to give estrogen with the selective progesterone if the patient has a uterus, and that will improve her fat mass and distribution, dyslipidemia, and insulin sensitivity. But remember that oral form can adversely alter the C-reactive protein, which is a pro-inflammatory marker, and it can also increase the triglycerides, and that will weaken the beneficial effects of hormone therapy on the cardiovascular system. And these are the estrogens which have been given during menopause for a person who wants to have therapy to prevent, to treat metabolic syndrome, along with the particular treatment for that form of metabolic syndrome. And when you want to add progesterone, the continuous regimes are much better than the sequential regimes. And transdermal estrogen is much better, but even then progesterone need to be given. But suppose the patient's got sleep difficulties, probably you can add the newer forms of micronized progesterone at night compared to medroxyprogesterone, because it gives a better sleep pattern. And hormone therapy can also be used to reduce the chance of developing new onset diabetes and decrease the blood pressure sugars in a person who's already diabetic. But using it for the management of cardiovascular disease is controversial. And we have to remember that with hormone therapy, the benefit is not with the cardiovascular system. It can have beneficial properties for the other components of metabolic syndrome. But even when you're going to use it, you have to use it very carefully, individualize the therapy, and always evaluate the patient before you start. And according to many systematic and meta-analysis, hormone therapy does not affect the incidence of cardiovascular disease, and controversially can even increase the risk of cardiovascular events if it's not used appropriately. So I'd like to conclude by saying that metabolic syndrome in menopause can be prevented by a combination of diet, exercise, which should be done to reduce sarcopenia, and there should be an appropriate individualized intake of vitamins and supplements, and drugs have to be given as per the disease of metabolic syndrome which the patient is manifesting. Thank you so much. And this is actually the slide which tells about it, but Geeta was so clear in her talk on sarcopenia. But sarcopenic obesity is the one which we need to always remember, that it's the main reason for inflammation, insulin resistance, muscle wasting, reduced activity because of muscle wasting. There'll be reduced energy expenditure. There's a positive energy balance, and that will add on to the obesity again. Thank you so much. I think I finished ahead of time. Prerna, you have to unmute yourself. Please unmute Prerna, no? Please. Some special...
Thank you. Thank you so much, Chamila ma'am, for your wonderful deliberation. It was indeed a pleasure to hear you speak. We have our next speaker, Dr. Sujata Dalvi ma'am, who will be speaking on osteoporosis prevention. Can we have ma'am CV, please? Dr. Sujata Dalvi ma'am's CV, please. Yeah, ma'am, we are really honored to have Dr. Sujata with us. She is the consultant OBGYN at Saifi Bhatia St. Elizabeth Hospital and honorary clinical associate of the Neurosurgery Vadia Maternity Hospital. Ma'am is the treasurer for MOGS, and we are really honored to have you, ma'am. The dais is all yours for your next talk, that is on osteoporosis prevention. Dr. Sujata Dalvi, ma'am.
Is she there? Because I think madam needs to be unmuted if she's there. Sujata ma'am?
Sujata ma'am?
Please put a message in the group if you're there.
Madam, I'll just call her and check.
Yeah.
By the time, if we have our third speaker, Dr. Riti Mehra, can we take her up? Dr. Riti Mehra, are you logged in?
Yeah, I'm unmuted. Can you hear me? I'm
Yes,
Dr.
Dr. Reeti.
Reeti here.
Yeah,
Can
yeah,
you
yeah,
see
yeah.
me?
Yes, yes. Can we have Dr. Reeti Mehra's CV, please? Yeah, the next one.
Shobha madam wants to be
Yeah, thank you.
unmuted, please.
Since our second speaker is on the way and we need to not waste much time, so we're inviting Dr. Reeti Mehra ma'am, President CRMS and working as a professor of OBGYN at GMCH 32 CHD with 25 years of teaching experience. We are really, really honored to have you amongst us, ma'am. Dr. Reeti Mehra will be speaking on osteoporosis management and the dais is all yours, ma'am.
ICOG team, please unmute Dr. Shobha Gudia. She's one of the conveners.
Thank you so much for having me. I must thank all the organizers at the outset. Can you see my screen?
No, madam, no, it's not shared yet.
I have shared it.
Please unmute Dr. Prerna. Why is it happening again and again?
Yeah, I tried to
she
speak
can.
to Dr. Sujata. She is not responding. Yeah.
Hi, Dr. Shobha. How are you?
I'm good,
I
Reeti.
am.
Hello, I'm Dr. Priya. I just spoke with Dr. Dalvi. If we could
Okay.
have the third speaker to talk, and
Yeah,
Madam
we
will
are.
join
We
in
are.
10-15 minutes.
Okay, fine.
Okay.
Okay,
Dr.
fine.
Reeti, yeah. We can have the
But
second speaker after Dr. Reeti.
Yeah, but my
she
screen is not
will
getting
log in.
shared. I am trying to share the screen.
You
Yeah,
log out
host,
once
please
and log in
enable
again.
screen sharing, no, for Dr. Reeti Mehra, please.
Madam, once you are made a co-host, you can always screen share, madam. There must be some other problem.
I am putting screen share, but it's not sharing. My video and voice is audible, right?
Yeah, you're audible.
And my video is also.
And you are a co-host.
You are not seen, ma'am, but we can't see your face.
मैम फर्स्ट तो आप अपना पीपीटी ऑन कर लीजिए फिर शेयर करिए उसको
पीपीटी ऑन
can't
करूं?
see you, Dr. Reeti.
हाँ पीपीटी को पहले ऑन करिए उसको मिनिमाइज करिए देन जूम पे आके उसको शेयर करिए
पीपीटी इज ऑन यस
यस फिर आप जूम की स्क्रीन पे आइए आपको डाउन साइड में एक शेयर स्क्रीन का ग्रीन कलर का आइकॉन दिखेगा
I am pressing on that.
यस उस पे क्लिक करिए आपको पीपीटी का विंडो दिखाई देगा जो आपने पीपीटी ओपन करके रखी है
Share with the Chrome tab window entire screen.
आपकी जो एप्लीकेशन विंडोज जो ओपन होंगे ना वो आपको दिखाई देंगे इन अ स्मॉल आइकन बस आपको वो पीपीटी को क्लिक करना है और शेयर करना है
दिख नहीं रहा है
Actually, we can't see your screen also. So probably we have to share the full screen and then keep the PPT open on the screen and then share the screen. Then it will be seen immediately.
The PPT is open on the screen.
Okay. Then you share the screen. You must be getting some options, no, when you share screen.
When it's coming, choose what to share with app Zoom.
Okay,
Chrome
तो
tab,
उसमें जो
window,
PPT
entire screen.
No, don't share the entire screen. There will be one box in which your PPT is visible. You click on that.
There is no box which is coming. Let me just take somebody's help.
Can you send it to the mail, please, so that we can share it for you?
Yeah.
Divya, can you
Meanwhile, has Dr. Sujata Dalvi joined? Because she told me she will join. Only thing is...
Not yet joined, ma'am.
Huh?
Dr. Reeti, can you mail it to our tech support?
I will do that. Divya, I'm sharing my screen. Why is it not? Why is my PPT
Prerna.
Yes, ma'am.
Prerna.
Yes, ma'am.
Has Sujata joined? Can you see her?
Not yet. She said she will join
told her
with
to
some
join.
time.
Now can you see?
Yes.
Yes.
Now,
Yes.
Bingo.
Make it
Yes.
into slideshow manner.
but I can still, yeah, just a minute.
नीचे है, third, fourth.
वो आवर क्लास आइकॉन है ना, उसको प्रेस करिए.
Okay.
नीचे.
How can?
नीचे
Lower
जाइए.
right corner. नीचे चले जाइए, lower right.
इस पे.
Yeah, then the third one. The third icon, not this. Yeah.
Next.
Yeah.
Excellent. Yeah.
Now you can see me?
Go ahead, ma'am. Yes, can go ahead,
Yes,
ma'am.
please go ahead. Yeah.
Okay. So actually my talk was supposed to be after prevention of osteoporosis, but I would come straight to management. And I hope the next speaker will now tell us how to diagnose osteoporosis.
Yeah, I'll talk to them about diagnosis. I totally forgot that it was today. I thought it's tomorrow. So it just
Okay. So we've already heard all the day-to-day non-pharmacological treatments, lifestyle modifications. We have to ensure when treating osteoporosis that dietary calcium has to be good, protein intake has to be good, vitamin D insufficiency has to be treated, weight-bearing exercise, falling risk has to be reduced. Very important. Keep the chappals on the side, have handbars, don't have rugs, don't have dogs and pets over which elderlies can fall. And so fall consequences are fractures, and they say you come through the pelvis and you go through the pelvis, because pelvic fractures makes you bedridden, and our elderly population, actually it gives you a high mortality. Coming to adequate intake of calcium, the IOM and the NAM have said adequate elemental calcium for more than 50 years of age, at least 1200 to 500, vitamin D3 between 800 to 1000 international units. Keep the levels between 30 to 50 is good enough. Vitamin D toxicity is also known, so we should make sure the levels are not above 50, at least 30 to 50 is a good value to keep. Combination of vitamin D and calcium reduces fracture risk, mostly well tolerated with minimal side effects. So all these three, stop smoking, medication, we've been hearing all these throughout the day. They help in prevention of osteoporosis in all women. Now, who are the women who have to be treated? We would initiate pharmacological treatment in women whose bone mineral density T scores at the hip or spine is less than minus 2.5, which is the WHO criteria for osteoporosis. A prior vertebral or hip fracture with minimal trauma or frailty fractures, where there is no accident history and the patient has had a fall, irrespective of the risk score on BMD, we can put the patient on pharmacotherapy. A low bone mass, that is on bone mineral density, if the T scores are coming -1 to -2.5, and the FRAX score is a score which gives you the fracture risk score. And if the 10-year probability of a hip fracture is coming more than 3%, or a probability of major osteoporosis related fracture is coming 20%, even if the BMD says low bone mass, that is osteopenia, but FRAX score is high, please give them pharmacotherapy. And this has been added by the Bone Health Osteoporosis Foundation in 22, as well as by the American Association of Endocrinologists in 2020, that a fracture of the pelvis, proximal humerus, or distal forearm in a person with low bone mass or osteopenia should be given pharmacotherapy. So that would be the selection of patients who, without even thinking or giving a second thought, you should be putting them on pharmacotherapy. This is the new kid on the blocks, that is trabecular bone score. We've been hearing of bone mineral density score and FRAX score. The trabecular bone score is latest now on the block, where the FDA approved software is installed into the DEXA system, and this is a textural index. It has no value, it is unitless, but a high TBS, I mean, it has a value, but it doesn't have a unit. But a high TBS means the bone is normal. A low TBS means the bone is variable weaker. So TBS you can add to the DEXA, and it tells you that yes, the fracture risk may be higher, independent of just a minus 2.5, what we are taking as diagnosis of osteoporosis. And if the 10-year fracture risk is 15 to 19% of a major hip fracture, In the Canadian guidelines, which have come in 2023, they have added that you can consider treatment. The earlier ones which I mentioned were recommended, totally recommended. But if it is between 15 to 19%, you can consider treatment. I will come to this chart if I have the time. Now, what to evaluate once you are diagnosed with osteoporosis? So if you have diagnosed osteoporosis on a bone mineral density, there are fracture risks available, the patient's history is available, you've put in a frac score, patient's fracture risk is high, we must evaluate any cause for secondary osteoporosis. Thyroid, parathyroid, drug intake, steroid intake, osteoarthritis, or vitamin D deficiency, evaluate for any vertebral fractures. So once you've seen BMD is not good, BMD is being done at the hip and spine, you should be doing an X-ray lateral view, preferably of the spine, to see whether she has any vertebral fractures. Consider using bone turnover markers in the initial evaluation, because this will help you when you're putting the patient on osteoporosis pharmacotherapy. What are the bone turnover markers? I'll just come. And elevated levels of bone turnover markers tells you that there is a rapid rate of bone loss and a higher fracture risk. So it corroborates that, yes, you are giving the treatment right. And it also helps you follow up the treatment. Like you've got a BMD, which is weak, you're putting the patient on drugs, you do the bone marker resorption, the resorption bone markers. And if the value goes down, you know, yes, I'm happy, my pharmacotherapy is working. So you don't need to repeat a BMD, say after 6 months. Your bone marker turnover markers will tell you that, yes, the patient is responding. The investigations, routine investigations, CBC, chemistry, calcium, phosphate, protein, albumin, busy slide, but these is just a list. Additional tests, only if indicated, would be thyroid, parathyroid, for celiac disease, for myelomas, cortisol, or bone marrow biopsy to look for marrow-based diseases. When a patient comes, as I said, for osteoporosis, we need to rule out the secondary causes. Lateral spine imaging should be done whenever the T-score is less than 0.1, or if there is at least one of the following: woman aged more than 70, men aged more than 80, a historical height loss of 1.5 inches, self-reported but undocumented prior vertebral fracture, glucocorticoid therapy of more than 3 months. Here in this slide here, we can see that the bones are weak, and these are compression fractures here, very clearly seen. So they tell you that, yes, even if the BMD is showing okay, we need to put her on pharmacotherapy. These are the bone marker turnover markers. Endocrinologists, I was talking to them, they really use the CTX, and CTX should be used especially if you're using teriparatide. I'll be coming to the various pharmacotherapies, and this, it's important to remember that they cannot be used to diagnose osteoporosis. Elevated levels can predict more rapid rates of blood loss, because this is a bone resorption marker. So if it's elevated, you know that CTX is elevated, she's rapidly losing bone loss. They fail to verify, they are not good predictors of hip fractures. So those with CTX high, you cannot say, oh, I will start pharmacotherapy, oh, she's likely to have fracture, but they respond quickly to therapeutic intervention, which is very good. So you can see, so they are used to monitor treatment. These are the two which endocrinologists are using it. The CTX, it is called, and PINP. PINP is a bone formation marker. CTX is a bone resorption marker. So when you give them pharmacotherapy, these bone CTX values go down. You know that, yes, my denosumab or whatever you are giving is working. So all the fundamental advice we've already said, we will tell her all this, that is vitamin D, calcium, limit alcohol, stop smoking, active lifestyle, and refer for physical therapies. Reduce the risk for falls. Tell them to use a stick. No point, I want to look young, I don't want to use a stick, is not going to work. Using a stick can be fall preventive. Using good slippers so that they don't slip. Put away the rugs in the room of the elderly. All these features are very important for reducing risk of falls. Coming to the drug therapy, these are all the drugs that we have. This is the entire market. Bisphosphonates, which are alendronate, risendronate, ibandronate, zoledronate. All of them are present in the Indian market. The SERMs, raloxifene, it is available in Indian market. Calcitonin, comes by many names, but it's usually a nasal spray. We can use ERT or E plus P. Anabolic drugs, which are as of date only teraperatide. Denosumab is also not an anabolic. It is very much anti-resorptive. But we have romosozab, which is the new kid on the block, which has come in the market, not in the Indian market as yet. But so anabolic drugs, which are bone building drugs, are only teriparatide and rozosumab. I have not put romosozab. I've forgotten to put it here. But denosumab is a rankle activator, and this is also an anti-resorptive agent. All these are anti-resorptive. That is, they are inhibiting the osteoclast so that bone resorption gets reduced. Anabolic are those which are helping in bone formation, which are only parathyroid and rosozumab. Okay, so how will you start and monitor treatment? You will obtain a baseline DEXA scan, and you will do it every 1 to 2 years. It is recommended that follow-up should be done by the same facility in the same machine, and preferably by even the same technician. Use of markers they are expensive, and so you can use them, but it will assess patient compliance and efficacy of therapy. Bisphosphonates are usually the first line drug that is being used by orthopedicians, by gynecologists, by endocrinologists. They are FDA approved, and they prevent as well as can treat osteoporosis in postmenopausal women. They are also used for treatment of glucocorticoid-induced osteoporosis and Paget's disease as well. And they are leading to increase in bone density, reduce fracture risk, basically by promoting phagocytosis of osteoclasts. Now, various dosages. Alendronate, it's also available as 70 milligram weekly. Always add vitamin D and calcium. Risendronate, you can have it daily, weekly, fortnightly, or even monthly. You can have it once a month, 150 milligram. Ibandronate is also daily or monthly. IV is also available. A very good drug, which I have personal experience also using, especially for women who don't want to have a tablet daily, who cannot, are having GI side effects with ibandronates. You just give one injection of 5 milligram over 30 minutes once a year, supplement with calcium and vitamin D, and you forget. You can call her after 1 year. So it's a very good drug because the compliance is very good. And oral administration, you have to tell if they're taking orally that it has to be taken half an hour before the first food, and tablet should be swallowed with a glass of water, and after that patient should be upright, walking, standing, or sitting for at least 30 minutes because it can cause a lot of heartburn. And it should be supplement and acidity, and it should be supplemented with calcium and vitamin D. So first line, according to the ACE 2020 guidelines, the first line agents are all these: alendronates, risendronates, zolendronate, or you could use denosumab, which is a rankle activator. These are all bisphosphonates. For those for high fracture risk, very high fracture risk, who are unable to use oral therapy, you can use abloparatide, denosumab, romosozumab 1 and 3. These are anabolics. Denosumab is anti-resorptive. Teriparatide is anabolic. And zolendronate, which is IV injection, can also be used as a first line who's not tolerating oral therapy. For spine-specific indications, there are ibandronate and raloxifene. If you have to use one after the other, you give first anabolic, which is teriparatide or romosozumab, and then this should be followed by a bisphosphonate or denosumab or raloxifene. Side effects could be hypocalcemia. GI side effects are the most, and long-term use has given rise to osteonecrosis of the jaw and atypical fractures. Atypical fractures is a big risk, and you will usually find both the sides of the bones are involved, and the bone margins are sclerotic because it's given you a high density bone, but the fracture is extending through both the lines and with minimal trauma, and they are very difficult to treat. So they are actually a nightmare for the orthopedician. One has to do surgery, and you will have to add teriparatide now for treatment. So that is why what is prescribed with bisphosphonates is a drug holiday. And Drug holiday, I'll come to drug holiday, but the contraindications for bisphosphonates is any abnormalities of the esophagus, inability to sit up straight for at least half an hour, patients at risk for aspiration, hypocalcemia should be corrected. So she should be given good vitamin D before you consider bisphosphonates. Renal insufficiency, it cannot be given. Bisphosphonates cannot be given with creatinine values which are high. If you're using monthly doses, it's a missed dose. If the next dose is more than 7 days away, you take the morning dose and then return to the original schedule. If the next dose is less than 7 days, just wait for the next dose. But you cannot take 2 tablets of 150 milligrams in the same week. Yes, I was talking of bisphosphonate holidays. These holidays should be considered in patients after 3 to 5 years and those with low or moderate fracture risk. But those with very high fracture risk, you can give a drug holiday after 6 years also. No need to stop it after 3 years. Zoledronic acid after 3 years. If you're giving us injection every year, you give 3 injections, then give a drug holiday if the patient is at low or moderate risk. If you are on oral bisphosphonates, then you can give a drug holiday after 5 years, that too in patients with low or moderate risk. Okay. And if the patient after 5 years, we reevaluate the patient. If the patient is still at a high risk, you can continue the osteoporosis treatment, or you could switch to another agent. Raloxifene is a SERM, selective estrogen receptor modulator. It is approved for prevention as well as treatment of osteoporosis. It's a tissue selective, and so it has beneficial effect on the breast, no harmful effect on the uterus. You could give it 60 milligram once a day and should be supplemented with calcium and vitamin D. Hot flushes, arthralgias, slightly higher incidence of DVT, so those who have vascular disease should not be taken. Chest pain, insomnia, migraines have also been reported. So do not use raloxifene in those with DVT, high risk for pulmonary embolism, cardiovascular disease with uterine or cervical cancer, and in prolonged immobilization, we discontinue it at least 2 days before.
Oh, ma'am, your time is up.
Okay. So there is denosumab. Actually, I started very late. First you were waiting for another one. It's not 15 minutes yet. You've given me just 8 minutes. When I started, I saw the time. So just give me 5 more minutes to wrap it up as fast as I can. And coming to romosozab, this is a new drug and it is anabolic, and it is likely to be viewed as the rescue drug for those who are at very high fracture risk. But they have to be used in caution with recent MI or stroke. Calcitonin spray is a treatment for Paget's disease and is an adjunctive treatment for hypercalcemia. And it is also a good drug for those who are having vertebral fractures and have pain. So it relieves the pain as well as useful. So increases the spinal bone mass and decreases the risk of vertebral fractures. So that's a beneficial short-term effect on the osteoporotic vertebral fractures and the acute pain as well. You could use one spray on the alternate nares, one today, one spray next day on alternate nares. And contraindications are allergies. Coming to teriparatide. Teriparatide is as I said, it's an anabolic drug. It is quite efficacious. You have to give 20 units subcutaneously once daily and must measure serum calcium, parathormone, vitamin D, and alkaline phosphatase to rule out Paget's disease before we treat it with teriparatide. And these are some of the side effects. They are generally mild, but the patient has to inject themselves daily, and it is expensive. It has to be avoided in Paget's, in bone metastasis, hypercalcemias. Okay, so it is recommended for those with severe osteoporosis, at least one fragility factor, and who are refractory to or unable to tolerate bisphosphonates, or in bisphosphonates failures. So it's a good drug. MHT, just 2 slides on MHT, that it comes with the caveat that when using MHT, you should know that patients are at significant risk of osteoporosis and non-estrogen medications are not considered to be appropriate. For osteoporosis alone, yes, it will prevent, it will treat, but there are better drugs and with less side effects. So this is what a caveat has been given by the FDA. And of course, estrogen plus bazodoxifene prevents osteoporosis as well as vasomotor symptoms it reduces, and it's protective for the uterus. So that's a good combination which is available in the market, but not in the Indian market. How long should you treat a patient? With teriparatide, maximum you can give is 2 years. Romosozumab, maximum you can give 1 year. You must give a drug holiday after bisphosphonates, after 5 years if the fracture risk is no high, after 6 to 10 years if in those with very high risk for zoledronic, after 3 years. When to end drug holiday based on the individual risks of the factors. When to consult an endocrinologist when there are multiple fractures, major fractures, osteoporosis of the young, suspecting parathyroid disease, or no response to treatment. So I will summarize. It's a chronic progressive health issue, requires lifelong management, encourage healthy lifestyle. If indicated, must start pharmacological treatment, and for each patient, make an osteoporosis treatment plan. Oral bisphosphonates and IV zoledronic are the most cost-effective interventions for those who remain at high risk after 3 to 5 years, because a drug holiday is needed after oral or IV zoledronic, then switch to another drug. And for denosumab, there is no limit to duration. You can even give it for 10 years. But if you're starting denosumab, which is a rankle activator, do not stop and then not start treatment, because bone loss is suddenly going to come back again and very rapidly, and it will result in vertebral fractures. So always after denosumab, start on something else. And teriparatide, these are anabolics. They should be considered first line for those with very high risk, for second line, and initiate after treatment. Treatment with teriparatide you can do only for 2 years, with romosozumab only 1 year. After that, follow up with alendronate, zoledronate, denosumab, or relaxofene without delay. And clear information to be given to women so that they improve the adherence to this therapy, individualized treatment, eat high calcium foods, exercise regularly, do not smoke at a young age, and continue to grow. They say intellectual growth should commence at birth and cease only at death. Osteoporosis is a silent killer. It's really a silent killer, and we are seeing it much more in the Asian population, and must be tackled by all, by orthopedicians, by gynecologists, as well as by endocrinologists. So whenever they are coming to us, even for some other complaint, we should look out for features of osteoporosis. Thank you so much.
Thank you, Riti ma'am, for chipping in when we really wanted to save our souls. Thank you for chipping in early, and thank you for your wonderful
It was a pleasure.
Thank you,
It
ma'am,
was
for
an
a wonderful
honor.
deliberation. It was really informative, exhaustive, and totally elaborate management of osteoporosis. We now move on to our second speaker, Dr. Sujata Dalvi ma'am, who will be speaking on prevention of osteoporosis. Ma'am, the dais is all yours. Can we have Sujata ma'am CV? We have introduced ma'am earlier, but ma'am was...
That's okay then. In that case, I'll start sharing the slide.
Yes, ma'am. Yes, ma'am. Yes, ma'am. Ma'am, you can make it. Yeah, thank you. Thank you, ma'am. Yes.
1 second. I'll just make it.
Yeah, this is visible, ma'am.
Okay, fine. Okay. So actually, to be very frank, I thought it is tomorrow. So I was going to the clinic, and then somebody just called me up that it's today. So I came back. Anyway, I am supposed to be speaking on osteoporosis prevention. Before I start, I would like to thank the organizers and ICOG team for giving me an opportunity to speak on this subject of prevention of osteoporosis. We already heard how to treat osteoporosis, but it makes sense if you can prevent osteoporosis, then you do not have to take so much of treatment. So just as the previous speaker said, osteoporosis is a silent disease, and it's a disease of the first century. It's also become a public health issue so far as severity, chronicity, progression, and it affects postmenopausal not only women but also an elderly individual. There's always an imbalance between bone resorption and production. There's no pre-established clinical pattern, means you can't have a particular pattern that, okay, this patient is going to have an osteoporosis later. No, but uncomplicated osteoporosis always remain asymptomatic till some fracture occurs. That's when you realize that, oh, now that so-and-so is having an osteoporosis. It has multifactorial so far as osteoporosis is concerned. So it's related to nutritional, physical activity, lifestyle, medication, bone mineral index, endocrine, genetics, and of course, hormonal deficiency. So there are multifactorial present so far as an osteoporosis is concerned. Now, prevention of osteoporosis, if you go to see, it starts in utero itself. That is, they have done a study where children of mothers who have had a high frequency of intake of calcium-rich food during pregnancy, that is milk, milk products, pulses, non-veg food, green leafy vegetables and fruits, they've had a high total and spine bone mineral content and BMD, and children of mothers with a high folate status at 28 weeks of gestation had higher total and spine BMD independent of parental size, means irrespective of the size of the parent as well as the DEXA measurement. So what is more important, and in this study has been done, bone mass in Indian children, and this had been studied in 2006, where it is very important that you try and prevent osteoporosis right from in utero. So that makes more sense to give an extra calcium supplementation. So coming to calcium supplementation, so far as pregnancy is concerned, the fetal skeletal development requires about 25 to 30 grams of calcium during pregnancy, and calcium is mobilized generally from the maternal stores itself. Okay, so what you need is very important, is a enough source of calcium so far as pregnant women is concerned. So recommended dietary allowance for a women in a postmenopausal women is around 800 milligrams of calcium per day. And these are various food articles from where you can get calcium, milk and milk products, of course. Then there are so many pulses and green leafy vegetables. And you have a big chart of what all foods which are rich in calcium. And if take of these rich calcium rich food makes more sense so far as in calcium supplementation is concerned. International Osteoporosis Foundation has also put on an internet a calcium calculator. So depending upon what type of food you're taking, you can, at the end of the day, you can calculate how much calcium that you're taking per day. And that way you can change your diet, or maybe you can include calcium rich diet. So then the query comes, does oral calcium cause any renal calculus or even any cardiac problem? Can too much of calcium be not good for the body? So they have done a study. So doses more than 2,500 milligrams per day can affect the kidneys and can reduce absorption of iron, zinc, and magnesium. But our dose is always less than that. There is no cardiovascular problems or renal calculi seen with the recommended dose that we generally try and give it to the patient. Thyroid medication, corticosteroids, tetracycline, and anticonvulsants, these are the drugs which interfere with calcium absorption, whereas vitamin K, D, A, B12, and magnesium can be given along with calcium. So you can combine these vitamins along with calcium and can be given to the patient. Along with calcium, what is more important is vitamin D also. And in our tropical countries like that of ours, we have a natural vitamin D. So exposing 20% of our body surface area without sunscreen for at least about 30 minutes between 10 a.m. and 3 p.m. depending upon the seasons, latitude, altitude, pollution, and skin pigmentation. But sunlight between 11 to 2 p.m. is preferable. And that's a natural source of vitamin D. In case if that is not feasible, we can give vitamin D, can be given orally, and it is available in various forms like tablets, even the sachets, and the syrup form also it is available. We give about 60,000 international units once a week for about 8 weeks, and then later on once in a month for about 3 months, and that is for a storage. And of course, it also depends upon the summer and the winter season, and that's how you can make the changes so far as dosage is concerned. Now, prevention of osteoporosis, there are two factors that determine the bone mass at a particular age. One is a peak bone mass, and second one is a rate of bone loss. One attains a maximum peak bone mass and it reduces the rate of bone loss. So calcium-rich diet and of course exercise along with calcium-rich diet helps in prevention of osteoporosis. So in an adult, in addition to calcium and vitamin D, it's always preferable for them to have a regular physical activity, avoid smoking, and alcohol means too much of smoking and too much of alcohol. So far as possible, maintain the body weight, because they've seen that BMI less than 19 also means very thin and lean. That also damages the bone, and beware of any osteoporosis risk factors. And in case if it is there, then go for an early diagnosis and treatment. So go for a checkup, try and figure out what is a BMD, and that way you can just go for some sort of an preventive therapy so far as an adult is concerned. In an elderly, preventive measures in an elderly, in addition to calcium and vitamin D, there are some activities which can improve the balance, the posture, the coordination, and muscle strength. They have to follow some of the measures to prevent the falls, especially too much of an elderly. So they need to remove small things, like they need to remove loose rugs, remove some electrical items which are just lying, adequate lighting in all the areas, especially staircase, and also at night, even the washroom, there has to be a dim light so that they can see. Avoid walking on a slippery surface, avoid walking on an unfamiliar areas, and regular vision checkup is of an immense importance so far as an elderly is concerned, so as to prevent the falls. Now, there are certain endocrine disorders which the patients may be very prone to having an osteoporosis. So gonadal insufficiency, hyperparathyroidism, hyperthyroidism, hypogonadism, some of the like diabetes mellitus, nutritional disease, Cushing syndrome, some of the GI disorders like liver disease, celiac disease, and of course bone marrow related disease like hemophilia, leukemia, and of course those who are on organ transplantation, they are always on drugs which will reduce their immunity, and that's where they are quite prone to having an osteoporosis. There are some drugs which patients take, and they are also are prone to having osteoporosis, like anticonvulsant like phenytoin, steroids, cytotoxic drugs, SSRI like fluoxetine, high doses of methotrexate and levothyroxine, furosemide, antiretroviral, heparin, and high doses of vitamin D. Why am I saying this? Because if you find that the patient has been taking all these medications for quite some time, then it is always better to send the patient to figure out what exactly is a BMD, and that way you can start giving some preventive therapy so as to prevent an osteoporosis. What are the common sites of fracture that these patients could have it? One is scoliosis fracture, fracture for the neck of femur, spine, surgical neck, neck of the humerus, ankle and distal femoral fractures. Hip fractures are associated with almost about 8.4 to about 36% of an excess mortality within a year. And osteoporosis, mind you, again, I'm repeating, there is no clinical manifestation unless a fracture occurs. Only when a fracture occurs, then one can figure out, oh, so-and-so is having osteoporosis. Vertebral fractures are also most common clinical manifestation. Most of these patients are asymptomatic, especially in a bedridden patients. It's very difficult to figure out if they're having vertebral fractures. And there are symptomatic fractures where patients can complain of pain, deformity, loss of height, disability, and a stoop posture. Stoop posture, it's a major population problem, and stoop posture will always make you feel that, okay, this patient could be having osteoporosis. Now, how do you try and figure out whether she is having it or no? Go into the details of the history and try and figure out any risk factors. Clinical examination record height and weight annually. If you find that the height has been, there is loss of height over a period of 1 year, 2 years, whatever it may be, then maybe you should be suspicious that she could be having osteoporosis. Check the balance and the gait, especially the walk of the patient. Ask the patient to get up and go for the test by asking the woman to get up and go around from the chair without using the armrest of the chair, and that way you can figure out. And of course, as what I said, the kyphosis and the Dowger's hump could tell you that it could be a late stage of an osteoporosis. If you ask the patient to stand against a wall, you will find that that the occiput does not touch the wall at all, and there is some distance between the occiput. That will tell you that there is some sort of a problem in the thoracic spine, and she could be having some sort of an osteoporosis. And of course, if you're not able to insinuate 4 fingers between your lower rib cage and anterior superior iliac spine, that will also point towards possibility of an osteoporosis. What are the indications? Which are the indications of which patient would you send them for screening for an osteoporosis? Patient with fragility factors, then X-ray and CT scan showing some vertebral fractures or an osteopenia, DEXA scan, of course, with a secondary causes or high risk for fractures. And of course, if DEXA is not available, you can individualize the treatment by understanding the risk and the benefit and analysis of an intervention, depending upon what type of a therapy that the patient wants to take it. Now, does a hormone therapy, previous speaker has already said, does a hormone therapy work out so far as in prevention of an osteoporosis is concerned. They've done a study and they have found out that MHT per se is not as effective in reducing a fracture risk as the other products like a bisphosphonate. But they have said that in case patient has some other symptoms like a vasomotor symptoms and patient is on menopausal hormone therapy for the same, then it always helps over a period of time for prevention of an osteoporosis. Along with that, osteoarthritis and osteoporosis are common accompaniments of a patient seeking an MHT, and there is a stretch of the reach of an MHT so far as treat and prevention of an osteoporosis is concerned. So if there is an indication to give MHT, if there are no contraindications, please go ahead and give MHT. Over a period of time, it will always help in prevention of an osteoporosis. They had studied about 1,500 women, and they were divided into 3 groups: current users of MHT, past users of MHT, and a group that had never used an MHT. They had done a bone mineral densitometry at lumbar spine, femoral neck, and total hip, and they have found that MHT was associated with bone microarchitectural preservation as assessed by TBS, that is trabecular bone score, and effect of MHT on TBS and BMD persists for at least 2 years after withdrawal. So even if the MHT is stopped, it always has a good effect for at least next 2 to 3 years, and that's how it helps in prevention of an osteoporosis. So over a period of time, does HRT, especially if she is symptomatic, will help or no? Definitely, it will help in prevention of osteoporosis in perimenopausal and menopausal women, but you need to give it with calcium and vitamin D. And of course, in case HRT is contraindicated, then bisphosphonates are the medications with antacids to counteract the side effects, and these are the ones which can be used for prevention. We have rich grandmothers and relatives who are on wheelchairs. There are some patients with or without renal failure. Would you still advise preventive therapy for them because they can't take oral bisphosphonates as they are bedridden? So do you think that we can give them something else like an injectable so as prevention of an osteoporosis? And which one would you like to give? You can give IV bisphosphonates also, provided creatinine clearance is more than 30 to 35, and in a patient with a severe renal failure like in CKD stage 3 and 4, one can opt for denosumab or raloxifene. Of course, my previous speaker has already given you the details, but you can still use these medications so far as prevention of osteoporosis is concerned. So to conclude, osteoporosis is a non-communicable illness. Preventive therapy is necessary so far as geriatric group is concerned. Good nutritious diet with adequate calcium and vitamin supplementation always helps. Exercise with an adequate physical activity is of an immense importance. Pharmacological therapy can be given if an established osteoporosis or if there is a fragility factor. Osteoarthritis and osteoporosis are common accompaniments of women seeking MHT or an HRT, and we should stretch the reach of HRT to treat and prevent osteoporosis in such patients. We should not go behind and not give them MHT if at all they need it and it is indicated. Thank you so much.
Thank you, ma'am, for that wonderful deliberation. It was indeed quite informative, and we hope all the trainees have benefited out of it. So we move on to our next session. And with this, I thank all the speakers of session 2 for their very elaborative talks. And for session 3, we have chairpersons, Dr. Vandana Valvekar and Dr. Deepali Kale. Can we have their CVs, please? Dr. Vandana Valvekar and Dr. Deepali Kale, a chairperson for session 3, where we'll be taking up a little offbeat topics. Can we have Dr. Vandana Valvekar's CV? Thank you. Dr. Vandana Valvekar is former dean from. Hello. Dr. Vandana Valvekar is a former dean and Wadia Maternity Hospital and former president of Mumbai OBGYN Society and Indian Federation of Ultrasound and Medical Biology. Madam is a former Secretary General of the Association of Maharashtra Obstetrics and Gynecological Society. We are so very honored to have you amongst us, ma'am. And our next chairperson is Dr. Deepali Kale. Dr. Deepali Kale is a Yuva coordinator of AMOGS 2024 and a consultant OBGYN associated professor at the Wadia Maternity Hospital. We welcome you, ma'am, for this prestigious session. And over to you, chairpersons, for introduction of the speakers. Our first speaker is Dr. Anita Sa. Do we have Dr. Vandana and Dr. Deepali logged in? Dr. Anita Shah is a practicing OBGYN in Surat since 1988 and organizing secretary of National Conferences of Indian Menopausal Society in 2009 in Surat. And ma'am has various credentials to her cap, and she has a lot of publications and awards to her credit. We welcome you, ma'am, Dr. Anita Shah, and ma'am will be deliberating on financial planning. That is an offbeat topic, and the dais is all yours, ma'am. Dr. Anita Shah, ma'am. Are you there, ma'am?
Just to add on, Prerna, Madam is also President-elect of Indian Menopause Society in the coming year.
Great, great. Thank you, ma'am. We are really, really honored to have you amongst us, ma'am.
Yeah, thank you very much, Prerna. And thank you, Archana dear, for just adding the more one sentence. I'm really thankful to Dr. Parag and Dr. Parul Kotrawala and the whole team, ICOG, as well as Foxy team, for giving me this opportunity for this wonderful conference. I'll just share my screen. Friends, usually we always say that life begins after 40, and those who are involved to Indian Menopause Society, they are aware of the slogan of Indian Menopause Society: fit at 40, strong at 60, independent at 80. So we just believe that life begins after 40, but menopause and financial planning, it is very, very important. Of course, this is a little bit offbeat topic, but I would like to discuss it in fluently. The menopause is not only a stage of life most women experience, both mentally and physically. It is also a time when finances can be adversely affected. So what plans can they put in place to ease its impact? Financial planning during menopause is a crucial step in ensuring long-term financial security and stability. Menopause, typically occurring in women between the ages of 45 and 55, marks significant physical, emotional, and lifestyle changes that can also impact fitness, finances. Planning for this stage involves addressing potential changes in income, healthcare cost, retirement goals, and lifestyle needs. Much has rightly been written about how women are often at a disadvantage to men when it comes to building savings and pensions over a lifetime. This is typically attributed to a variety of reasons, such as the gender pay gap and the fact that women often take time out of work to be primary caregivers, be that for children or for elderly parents in the family. Until recently, however, very little has been said about the impact of the menopause on women's finances. Indeed, the menopause has remained a largely taboo subject. But now we are just observing that more and more discussion is going on regarding menopause, because in 21st century, our lifespan has increased, and woman passes more than 1/3 of the life in the postmenopausal age. So she has to remain financially also stable during that phase of life. However, thanks to awareness raising by celebrities and work of campaigns for women's issue, the menopause is increasingly being discussed. The reality is that the vast majority of women will experience menopause symptoms. This can be wide-ranging and may include anxiety, brain fog, depression, memory problems, joint pain, hot flashes, fatigue, and whatnot. All of this can be extremely debilitating, and many directly affect a woman's ability to work, with a subsequent impact on her finances. Many women feel a distinct loss of confidence while going through the menopause. This can slow down career progression, as they may be put off going for a promotion. Indeed, research reveals that 27% of women say the menopause has had a negative effect on their career progression. Maria Evandro, professor of gerontology at University of Southampton, who has studied aging and life course events for 30 years, says that many women don't feel confident talking about the menopause in the workplace in case they are viewed as potentially not competent to be given a higher level task or more senior role. This lack of career progression would potentially result in a loss of future earnings, money that would have been in the bank and had they progressed up the career ladder. It is also essential to note that in a marriage or partnership, a woman may be the main breadwinner, potentially earning a higher salary and contributing more to joint savings, mortgage payments, and expenditure. This would result in a significant financial impact on the family. At the most extreme end of financial impact is the potential for divorce too. How to plan for the multi-factor? While most women will go through the menopause, every woman's experience is going to be very personal to them. The average age for a woman to reach menopause is around 47 years, but symptoms can begin years or even decades earlier during what's known as the perimenopause, as you all are knowing very well. The severity of the menopause is also unpredictable. As mentioned earlier, some women will suffer moderate symptoms that may not impact on their work too adversely. However, some will have to stop work altogether, be that on a permanent or temporary basis. This makes financial planning all the more challenging. In short, the menopause is one of the several common life events that can adversely affect your financial profile. In our Gujarati, there is a very well-known proverb, Nana vagarno na thiyo ne nane na tha lal. So money is not everything, but it is needed. The reality is that many women will likely have to take some time out of work in their lives, be that to raise children, take care of sick relative, or because of the menopause. This is where the value of financial planning really shows importance. By building in case buffer, maxing out savings and pensions, and making the most of tax incentives as early as you can, it is possible to ride out the ebbs and flows of life. If you have to reduce the days you work, go part-time, or stop work for certain periods, for whatever reason, it is essential to build that into your overall planning. Having planned ahead, it is easier to make any adjustment necessary depending on the level to which a woman is affected by the menopause and any other life course events happening, such as taking care of sick parents and children going away for studies outside. Married women or those with partners may also want to consider the role their spouse or partner can play in financial planning. Can they increase contributions or savings and pensions? Or would it be more efficient for them to liquidate certain assets? How can employers impact? The menopause is increasingly being recognized by employers as a health issue they should be providing support for. Workplaces need to consider employment-based options for women going through the menopause. Is there flexibility to work from home? Can you do a senior management job part-time? Could you have unpaid leave for a year and then you again come back? This not only supports the woman, but means that business don't lose highly skilled, valuable talent of a elderly woman. What is next? Having a financial plan in place means that once you are actually experiencing the menopause, you are not having to worry about paying the bills. And if you need the time out, you know you can because you have planned for it. Most of the menopausal women are always asking, are we okay financially? It is a great question. Of course, there is still stigma associated with menopause, but with more awareness, flexible employment options, and a wide range of financial products, women in 10 to 15 years' time will be able to travel through the menopause in a slightly less bumpy way. In other words, will be able to sail through menopause smoothly. How can a menopausal woman get her finance while taking care of her physical and mental health during menopause. Balancing finance while managing mental and physical health during menopause is crucial, as this life stage can bring unique challenges. Here are some strategies to help you navigate this period effectively. Various strategies you can see. Build an emergency fund. Aim to save 3 to 6 months worth of living expenses in an easily accessible account. This fund can provide a safety net if you need to take time off work due to menopausal symptoms. Review and adjust your budget. Regularly evaluate your income and expenses. Identify areas where you can cut back, especially if your work hours or income change due to the health issues. Plan for potential career interruptions. Consider creating what if scenarios in your financial planning. This includes estimating how much money you might need if you decide to take a break from work. Seek professional financial advice. Consulting with a financial planner can help tailor a strategy that aligns with your current situation and future goals, especially regarding retirement planning and investments. Health and wealth also. Prioritize physical activity. Regular exercise can alleviate many menopausal symptoms such as anxiety and weight gain. Explore free online resources for workouts that suit your fitness level, including yoga and strength training. Focus on nutrition. A balanced diet rich in calcium, vitamin D, protein, and plenty of fruits and vegetables can support overall health during menopause. Staying hydrated is also essential. Practice stress management techniques. Incorporate relaxation techniques such as meditation, deep breathing, exercise, or spending time in nature to manage stress levels effectively. Establish healthy sleep hygiene. Prioritize good sleep by creating a calming bedtime routine, keeping your bedroom dark and cool, and avoiding screens before bed. Utilize support networks. Engage with family, friends, or support groups who understand what you are going through. This emotional support can be invaluable during challenging times. Mind-body practice. Yoga, regular yoga practice can improve sleep quality, reduce stress, and alleviate hot flushes through a combination of physical activity and mindfulness. Tai Chi, this gentle form of exercise, can help manage stress and improve overall well-being during menopause. Aromatherapy, using essential oils such as lavender and chamomile can promote relaxation and improve sleep quality through inhalation or topical application. Lifestyle adjustments. Regular exercise, engaging in aerobic activities like walking and swimming can help manage weight, improve mood, and alleviate hot flushes. Stress management techniques, incorporating practices such as meditation or deep breathing exercises can significantly reduce anxiety and irritability associated with menopause. And again, you have to maintain your sleep hygiene. So balancing finances while taking care of your mental and physical health during menopause requires proactive planning and self-care strategies. By focusing on both financial stability and well-being, you can navigate this transition more smoothly and maintain a healthier lifestyle. Because if you will take care of yourself, if you will remain healthy and happy, then you can manage your financial burden also in a very easy, nice way. How will you manage financial planning? Long-term financial planning. For that, importance of savings. Ensure you have adequate savings and investments to support you through menopause and beyond. Revisit financial strategy. Regularly review and adjust your long-term financial plan to align with evolving goals and future financial security. Consider diversifying investment to reduce risk and protect future income. Emergency fund. build or maintain an emergency fund with 3 to 6 months worth of living expenses for unexplained events. Focus on future needs. Increase savings for both emergencies and long-term goals as part of your financial strategy. Insurance needs. Today, everyone is taking insurance for the Mediclaim and everything. You also have to take care in that direction also. During menopause, reviewing and adjusting insurance policies is crucial to accommodate changing health, lifestyle, and financial risk. Long-term care insurance. As the risk of needing long-term care increases with age, it is essential to evaluate long-term care insurance options. Buying this insurance in your 50s can be more cost effective than waiting until later when premiums are very much raised. Life insurance. Access whether you need to maintain or increase your life insurance coverage, especially if you still have dependents or outstanding debts like a mortgage. Disability insurance. Ensure that you have adequate disability insurance in case menopause-related health issues such as chronic fatigue or other conditions affect your ability to walk. Menopause is an opportunity to take charge of your financial decisions and plan for the future. Financial literacy.
Mom, your time is up.
Yeah, just only one minute only.
Yes, ma'am.
Enhance your financial knowledge to ensure long-term security and peace of mind. Seek professional advice. Consult a qualified financial advisor for personalized guidance tailored to your circumstances, because most of we are zero in this direction. Build confidence. Understanding your financial situation and options helps you feel more confident and prepared for the future. So in conclusion, I would like to say financial planning during menopause is essential to navigating the physical, emotional, and financial transitions of this life stage. It involves reassessing healthcare costs, retirement plans, income streams, insurance coverage, and lifestyle needs. By taking a protective approach to financial planning, women can secure their financial future and ensure they are prepared for the changes that menopause brings. Working with a financial advisor, creating a solid budget, and keeping track of your changing needs can help ensure a smoother transition through menopause and into retirement. So only then we can just fulfill the slogan of our Indian Menopause Society, that fit at 40, which I have elaborated in a little more in a better way. Fancy at 50, strong at 60, sexy at 70, independent at 80, naughty at 90, and healthy at 100. We want that each and every woman, midlife woman, should remain healthy till the age of 100. But proper financial management is a must. Thank you very much.
Thank you so much, ma'am. This topic was indeed an eye-opener, and every menopausal woman need to have this topic delving into deep for having a financial, social, as well as emotional security. You are way too good, ma'am. Thank you so much. We are honored to have you amongst us, ma'am. So we move on to our next speaker, Dr. Hefziba Kirubamani, and she'll be speaking on another very interesting topic, how to set up a menopausal clinic. And can we have Dr. Hefziba's CV, please? Yeah. Ma'am is a former superintendent of government RSM hospital and professor of Stanley Medical College, and currently professor of obstetrics and gynecology at the Sarita Medical College. We are really, really honored, ma'am, to have you amongst us, and the dais is all yours, ma'am. Ma'am, are you there?
I think she's not in here.
We don't have her logged in yet.
No, ma'am.
Can we move on to the next speaker?
Can you call her?
I'll give her a call.
We move to the next speaker, but please call her and confirm.
Yes, I will. Do we have Dr. Sarita logged in? Dr. Sarita Shamsundar? Dr. Sarita, are you there?
Actually, Prerna, I cannot see her in the list. But
yeah, she's there. She's there.
She's there. She's there.
Yeah, she's there. So, ma'am, will you mind chipping in prior to the next speaker.
Yeah,
Yeah.
yeah. One
Yeah. Thank you so much, ma'am. Dr. Sarita Syam Sundar is the professor and unit head of oncology, Vardhaman Mahavir Medical College, Safdarzung, New Delhi. And ma'am is a board member of International Federation of Colposcopy and Cervical Pathology and organized Asia's first IFCPC World Congress of Colposcopy and Cervical Pathology. We are so very honored to have you amongst us, and no better person to speak on this topic on screening for CA cervix and endometrium. Ma'am, the dais is all yours.
Thank you so much, Prerna, and thank you to ICOG for this invitation. I'll just start sharing my screen. Can you see my slides?
Yes, ma'am, visible. You can make it in the slide mode.
Yes, I will. Yeah, so thank you once again. So first, the first and foremost, the cervical cancer is the second commonest cancer in our country. So I'll be talking about that first. So we have guidelines from the WHO and the FOXI GCPR guidelines also. The WHO made guidelines in 2021. So in 2018, actually, the WHO gave a call for cervical cancer elimination, where if we have to achieve cervical cancer numbers of less than 4 per 1 lakh women. Right now we are at 17.7. So that is a world of free of cervical cancer. So if we vaccinate 90% of the girls, screen 70% of the women between 35 and 45 years, and treat 90% of the women with pre-cancer should be treated. So what are the WHO guidelines? So the WHO in 2021 laid guidelines for screening, and they have recommended HPV test as the primary test for screening because that is the most sensitive test. And with HPV, the screening should be between 30 and 50 years. And for women with living with HIV, it should be start earlier from 25 to 50 years, and every 5 to 10 yearly for the general population. And for those with HIV, it should be more frequent. It should be every 5 yearly. Now, if HPV test is not available, we have to go ahead with screening with whatever test we have. So if it is VIA or PAP. So with PAP, it is every 3 yearly from 25 to 65 years. So these are the various tests which are available for screening. For the HPV test, we have the nucleic acid, we have the HPV DNA test and the RNA test. And then where these other tests are being developed. And then the pap smear, we have the conventional pap smear, we have the liquid-based cytology and dual staining also. So where we can both, that is P16 and Ki67. So if this is used for triaging the HPV positives. And then the visual methods, we have visual inspection with acetic acid. Either we can see that with the naked eye or with the augmented visual examination devices. So what is the accuracy of these screening tests? Now, the cytology or the pap smear, the sensitivity is very variable and depends upon the person who's reporting the smear. But if the pap smear is positive, that means there's a very, very high likelihood that there is something abnormal. So the specificity is very high. Whereas with VIA, again, the sensitivity is variable and depends upon the training of the person, healthcare worker who's doing the test. But the specificity is varies between, it's around 85%. Whereas with the HPV DNA testing, because it is not a person doing it, it is not subjective, it is objective, it's being done by a machine. And so the sensitivity is very high. So it's 94%, and the specificity is also quite high, it's around 88%. Now the FOXI screening guidelines recommend age to start screening is 25 years in good resource setting, and universal recommendations start at 30 years and to end at 65 years with cytology, as I said, every 3 yearly. And with primary, how frequently to screen with HPV testing, it is every 5 to 10 yearly, and with cytology every 3 yearly. And screening after hysterectomy is not recommended unless unless she had CIN in the histopathology specimen. For immunocompromised women, that is women with HIV or any immunocompromised condition, start at 25 years. And so the preferred test is HPV test. Now, this is the operation framework guidelines of our government of India, which were laid down in 2016. And here and it is actually being followed in some states. The screening for common cancers, so women are being screened for common cancers, that is oral, breast, and cervical cancer. And the cervical cancer screening test recommended by the government of India is the VIA test, and the screening is to be done between 30 to 65 years by VIA, and they have to be referred to the primary health center or the district hospital for further evaluation. So as I said, when to start screening, 30 years with HPV, because a lot of women have HPV, are positive before that, and they clear it on their own. For women living with HIV, it is 25 years. There's a low incidence of cervical cancer in those women who are less than for 30 years, and there's a high incidence of regression of even HPV infection and the pre-invasive lesions. And when to stop screening, 49 years provided 2 consecutive negative screening tests with HPV. HPV tests have a high negative predictive value. So therefore, if HPV negative is at 49, the low chances of cervical cancer in the next 10 years. So because you need at least so much time for when there's HPV infection to the development of cervical cancer. So it takes around 10 years for the cervical cancer to develop. So therefore, you can stop at 49 if provided these screening tests have been negative. But if she comes at 50 years and has never had any previous screening, then she should be screened at least twice. The frequency of screening with HPV, it can be 5 to 10 yearly because it has a very high negative predictive value. And if HPV test is negative, you can safely leave them for 5 to 10 years. And the women living with HIV, it should be more frequent, 3 to 5 yearly. And the sampling can be either by provider or it can be self-sampling technique. If the HPV is not available, do not, stop screening. You can carry on with whatever method you're doing with the pap smear or with the VIA. So what are the principles of the HPV test? Because tissue culture is not possible, and HPV detection and typing is based on nucleic acid detection. So basically the nucleic acid in the DNA, that is in the virus, that is what is being tested. So there is cell lysis. So whatever the cells that you get, they are lysed and you get the DNA out of that. And then the genes, that is L1 and E6, E7 genes, they always are retained in the infected and neoplastic cells. So that's what you're going to test for. So there are various methods for the detection. So you can either go for the DNA test. So the DNA test, the direct genome detection, is the hybrid capture and the KR HPV test. So here, this is one of the oldest tests that is available. And then you have the amplification test and the amplification and genotyping. So in this, we have the COBAS and the expert HPV. So these are available, and the Abbott real-time HPV assay, and there are RNA tests also available, that is Aptima test and the Advantage HPV E6 test. So what are the FDA approved tests? So these are the tests which are approved. 5 tests have been approved by the FDA. One is the hybrid capture. This is the oldest one, which is approved it was approved in 2001. And a lot of tests, it has been there for a long time. Then the Hologic is another, the Hologic is the company, and Servista is the test, which is also FDA approved. COBAS test, which is by Roche company. And then Aptima test, which is by Hologic again. And the BD OnClarity test is by the BD company, which is this is the company which makes the Assure Path, the liquid-based testing also. So they are the different, so these are all the FDA approved tests which are available. So again, this is the table that shows you the different tests and the difference between the tests. And now, which are the tests which are recommended for primary screening? It is the BD test and the Roche, that is the COBAS HPV test. And the genotyping is possible for the BD. I mean, you can get tests separately for 1618 genotyping and also with a Roche HPV test. So which tests are better? Now, there was a study which compared all the 3 tests, so all the 5 tests, and the sensitivity for all of them was very high. It was more than 95%. So the HPV test can be done by the clinician, just like you take the cytology, the same way you just take the sample, or you can also go for the self-sampling. So the woman can take the sample herself and send it in the bag to the lab. So what is least expected for a resource constraint? If you have a resource constraint setting for frequency. So if you cannot go for those frequent screening at least once at 35 years, once at 35 and once at 45 years. So at least twice in the lifetime screening can definitely reduce the risk of cervical cancer. So then there are different approaches what to do next after the positive screening test. Either you can go for treatment at the same time. So the screening by VI or HPV, so you can go for treatment at the same time. And screen, triage, and treat is when there is a screening test which is positive, and that is followed by another test which is called the triage test. So there are various options available for triage, so we'll go through them. So what is screen and treat? So if you're screening with HPV, now HPV indicates that there is infection of the cervix. So whether that infection is causing changes in the epithelium, you will only know either by cytology or by VI. So by VI, if you find any acetobite lesions and you find them eligible, eligible for ablative treatment, that is, you're able to see the squamocolumnar junction, then you can go for ablation either by cryotherapy or thermal ablation at the same setting. But they're ineligible for ablation, then one can go for excision or LEDs. If you're again for screening with VI, if they're eligible for ablations, if the VI positive, if they're eligible for ablation, go for ablation. If they're not eligible for ablation, you can go for excision by LEDs. Now, what is screen, triage, and treat? So if any screening test is positive, so if pap smear is positive, then one can go for HPV for triage, or one can go for colposcopy directly if the woman cannot afford an HPV test. And if the colposcopy is positive, then go for a biopsy and treatment. So this is cytology. So if you have cytology, if you're anything more than ask us and more LCL, HSIL, all that goes for colposcopy. And if a colposcopy you find any lesion, then take a biopsy and go for treatment. If the colposcopy is normal, then go for a repeat testing after 1 year. So this is HPV. If you're going for HPV for primary screening, then either you can go for genotyping, that is 1618, or you can go for colposcopy for triage, or you can go for cytology for triage. So this is screening with HPV and triage with genotyping. So because 1618 are the ones which are at very high risk. So if those are positive, then definitely go for colposcopy. Or just determine, if they're eligible for ablation. So just VI is also enough. So if the VI, we find that they're eligible for ablation, then go for ablation, or if they're not eligible for ablation, go for LEDs. And the other high-risk HPV are positive, then we can actually wait. So then any screening test positive coming for colposcopy. So if you colposcopy, you find a lesion, then if they're eligible for ablation, then you can ablate straight away, take a biopsy and ablate. And if not eligible for ablation, go for LEDs. Because a lot of women do not come, there's a high chances of lost follow-up. So if they come for colposcopy, it's better that you go for biopsy and treatment at the same sitting. So then this is colposcopy, and if you do find HPV positive and go for colposcopy, but on colposcopy you do not find a lesion, that means it is not causing any changes on the cervix, then you can safely, say, okay, then you can come back after 2 years. Now so HPV test is positive, and straight away you're not able to send her for colposcopy, or the local area, if she's not able to go for colposcopy, then you can go for cytology triage. So this is, and if cytology is positive, then and if the cytology shows ascus or more, then one can go for colposcopy. So because HPV, again, we know whether this HPV is causing changes or not by cytology, we know. And then what to do after follow-up? Now, once the treatment is done, so if they're treated by ablation or LEDs, then follow-up can be done after 12 months. So you need not call them more frequently. So follow-up for 12 months by, again, HPV test can be used for follow-up. HPV is negative. Again, one test, another after 1 year. And then if they're negative, again, they can go back to routine screening, that is 5 yearly. But if at HPV test is positive at 1 year, then one can go for a retreatment or one can go for evaluation. Now coming to uterine cancer, how to screen for uterine cancer? It's very important is prevention. So healthy diet, exercise, weight loss, and if the women is on HRT, that should be stopped. And oral contraceptive use is actually very, very protective. Even 1 year of using oral contraceptives can protect against uterine cancer. So screening for uterine cancer routinely is not recommended, only for those women with Lynch syndrome or hereditary non-polyposis colon cancer. Yearly screening with transvaginal ultrasound should be done beginning as early as 25 years. And those women on tamoxifen, routine screening is not recommended, but only if they have bleeding or discharge. So in summary, cervical cancer screening should be between 25 to 65 years. HPV test should be preferred test for screening. And for HPV, one should start at 30 years, so 30 to 50 years, and 25 to 50 years in women living with HIV, and every 5 to 10 yearly. Now, if HPV test is not available, go for pap smear every 3 yearly from 25 to 65 years, or VI every 3 yearly from 30 to 65 years. Now, VI in peri and postmenopausal women is actually not recommended because the squamous columnar junction recedes inside. So it's preferable again between 30 to 50 years only. And screening for uterine cancer is not recommended routinely, but it should only be done in high-risk women. So it's, this 17th November is the day of the call for cervical cancer elimination. So, it's important to spread awareness. So please get informed, get screened, get vaccinated. So I urge all of you to spread this message in your respective areas. So get your relatives, your family members, the girls in your family, get them vaccinated and get all the women screened. Thank you so much for your patient hearing.
Thank you, Dr. Shamita. It was a great
Thank you.
insight.
Thank you, ma'am.
Love you.
Thank you, ma'am, for a wonderful session. Ma'am, thank you, ma'am, for a wonderful session. Yes, ma'am.
So, yeah, actually, Dr. Hepzibah madam is having some problem to join. So, with due permission of the chairs, I would just enumerate the points for her because she won't be able to join. The poor network is there. So,
okay.
First, we thank Dr. Shamita ma'am for such a beautiful presentation on a topic which is very, very important. As we all know, as the middle-aged or the midlife comes, we are more worried about the cancers. And many of the people are just not able to reach the hospital just in the fear complex. The doctor is going to tell what and what is going to happen to them. So with this prelude, I would like to share that why it is important to set up a menopausal clinic. I am actually not well prepared for this, and Hepzibah madam is not able to join, but I'm taking the privilege because the delegates are here to listen. Whenever we talk about the menopausal clinic, why it is essential, we had stalwart speaking from genitourinary syndrome to osteoporosis to other aspects, financial aspects, and cancers, cardiovascular health today. So the importance of menopause clinic is that we need to address such patients who are inside the house, especially in the Indian scenario. The patient comes out in the public whenever she's having some real problems, and silently she suffers for more than 25% of her life, because we all know the life expectancy is increasing day by day. More women start their life after midlife, that is after 35. So importance of menopausal clinic lies here, that we need to give a tender, loving care to the patient, and we should not miss the opportunity to screen the patient whenever she comes to us. The important point is that there is a need of checkup. So that is why the annual health checkup programs are running in many of the hospitals, which patients are not aware of. We are creating awareness sessions as a part of the FOXY organization and the IMS organizations. We try to spread the awareness that the menopausal health checkups are very, very important. So what should we offer to our patient? And as a dictum, menopause is not owned by anybody, or midlife is not owned by any specialty. It is a multidisciplinary approach where the patient is suffering from the comorbid conditions to the risk factors There are cases where there is a rise of premature menopause. That is, more of the cases have been reported. So whenever we get opportunity to screen a woman, go for the blood test, go for the head-to-toe examination. We should start from the clinical history, take the history properly. Also, the family history is very important because the genetic predisposition to certain comorbidities and also the cancers we lie down in the history of the patient when we talk about the family per se. Per speculum examination is our domain, and we should never forget to do a per speculum examination and a PV examination before jumping onto any of the diagnostic evaluations like ultrasound and the CT MRI, which is available. So important point to flash is taking a proper history of the patient's obstetric history. Her pregnancy miscarriage is also very important to address. Her family history is very, very important. And doing the blood investigations is as well important. What should you offer? Go for a basic hemogram, not just hemoglobin, go for a complete blood picture. That is CBC count is very important, where you will get to know about any factorial diseases like hidden, and CBC should be offered where you know the platelet counts. You can always just the vitamin B12 deficiency, looking at the picture of that. And you should offer her serum creatinine to know the kidney function, which is very important, her liver profile, her lipid profile, because these are the indirect markers of the high-risk CVD, having other problems in the later of life. And also go for the urine examination and ECG, 2D echo. Thyroid is something which we should not forget whenever we are subjecting our patient to the investigations, because baseline thyroid TSH disorders are detected mostly in the midlife, that is after 40. So TSH is an important parameter. There are certain patients who are worried about whether they are going to menstruate further or not, because irregular cycle is a very, very important component. So here, the AMH would be a good thing to offer to know her follicle, and the antral follicle counts are very important. The ultrasound should be done as a whole abdomen, not just screening the pelvic organs, because there are many other diseases which can be located by doing a simple per abdominal ultrasound as well. And we can always categorize the patient to go for the further investigations, depending on the ultrasound finding. The 3D and 4D in advanced ultrasounds in our clinic, I think we can detect many of the things in that. Also, the screening of the fasting blood sugar is very important. HbA1c is very important to know her diabetic control or predisposition of the diabetic status, along with the history. That is very important, which we need to screen. And if the patient is coming to us, we should always try to make a ECG echo as a component of our investigations, chest X-ray as a component of our investigation. Also, if possible, she should be subjected for a physician examination as well. And then if you find anything in the investigations which have been given to us, at that time, she can be subjected or directed to the specialized approach. Sometimes even by the talking, there is a history of stress. There is a history of some sort of anhedonia is one thing which is very, very important, where the patient doesn't want to enjoy or go for a component disorder which is the first line when you tend to detect the depression in our patients. She doesn't want to mingle with the society activities. She wants to stay alone. So these are the things which we can dig out when we have a menopausal clinic where the patient has one-to-one interaction. She knows that she's coming for the problems to be addressed. So these are the few benefits of that. Another important thing which Dr. Anita Shah Madam has already covered, that financial aspect can be discussed at this point of time. The counseling is very important part, where we can have a behavioral counselor also to tell her how to deal with the mental and the psychological changes that are occurring in her body, how to go and socialize, increase her social activities so that she's more a part of the society, she's not unwanted. There are people who would like to be taking a new career at that point of time, and they should be guided well. So Menopause Clinic gives us opportunity to take a career decision as early as 35, 40, 45, because she also has a right to go for a better quality of life where she's settled, her family responsibilities have been taken care of, so she can decide her career at this point of time as well.
you should have a yoga therapist with her or a physical trainer to train her into different weight bearing stretching exercises. That is what can be offered when we have a menopausal clinic, and dedicated exercise regime can be given and offered to our patients to set the goals and targets where she can achieve at that age where she has come. Because sarcopenia, frailty index, everything we have talked to the speakers ahead, osteoporosis. So we need to be addressing weight bearing exercises, stretching exercises, jogging, walking, balance exercises. Yesterday also we had a good discussion by Dr. Maninder Ahuja madam and Nirja madam talking about the holistic development of the female. So this is what we can offer when we have a proper menopausal clinic, where the patient enters and she is given a multidisciplinary checkups and a multidisciplinary opportunity to talk to the physician, to the gynecologist, to the psychiatrist, to the exercise expert, to the dietitian. And also she needs to be explained that if she forgets the thing, whatever we have given her as a prescription, if she forgets, it's all okay. You can offer her to maintain a diary where she can write her points, so that she writes a point, and there can be a level 1 and level 2 clinics as well. Level 1 where we can have a small dispensary in a rural setup, or where we don't have a hi-fi facilities. At least you can talk to her, try to elicit the things from the history, give her the basic investigations which are available, and from there you can refer her to the level 2 clinic where the super specialist can have a treatment protocol for her. So this is what I can say as extempore to the menopausal clinic. I think I would not be able to justify as probably Hepzibah madam would have been done. I tried my level best.
Thank you so much, ma'am. Archana ma'am, it was really very, very brilliant indeed. An extempore one, but yet so exhaustive and elaborative. We are really very, very proud of you, rather, that you could chip in right on time and could the delegates could at least beneficiate from whatever points you have entrusted. And it was really enlightening one. Thank you so much.
Thank you, Prerna. Shobha Gudi,
Yeah,
madam
Prerna.
wants to add something. Please add.
Yes.
Yeah, Shobha madam.
No,
you are here.
no, I joined a bit late. I was called away. Joined a bit. I was taking hospital calls. Archana, that was very nice, the way you have summarized it. I think that Dr. Hepzibah has actually made an app, and through the
She
app,
has, but she has sent me on the mail, but it's not reached me because of the network. So I just try to justify as
Let us see, Archana, if we are able to retrieve it, whether tomorrow we can post it for our delegates. Yeah,
We
whether
will do it tomorrow, ma'am. So I'll preamble. I'll do that because definitely
correct.
She has done
I think
such a good work.
that will be great if
Yeah,
we can get, because she has made a lot of effort and she has
Yes.
put in. Yeah.
Yes, ma'am,
She
and
has
she
put
is
in.
a lady who is a very hardworking lady, Prerna.
Yes.
Let me tell
Yeah.
you that not even as an IMS member, she is very good at playing at mouth organ. So that is what
She is a very talented
lung,
person. See,
I mean,
Archana, I just wanted to put in that from our society also, Bangalore society, and even in general today, we are trying to bring in more and more solutions for office gynecology. That is one stop where every care can be given to women. And in that, I think menopause care is one of them. We include their ultrasound, hysteroscopy, colposcopy,
Shobha,
and
people want to know about the level 1, level 2 clinic. I did explain, but
yes.
if you want to highlight more for some people, then you can take that call now.
Yeah, the thing is, the level 2 clinic is when there is identified morbidity and women non-communicable disease factors, and women definitely require hormonal therapy for their symptoms. So whenever symptomatic treatment is required, long-term follow-up is required. It will not be achievable when the standard is too basic, like a level 1. And a lot of multidisciplinary inputs are required, follow-up is required. For example, women who are diabetic, because NCDs are so common in India. So I think we need, and Indian women in midlife are at high risk for cardiovascular disease, right? So, and also hypertension. Added to that is cancer also. So I think level 2 clinics are where very strong multidisciplinary approach is needed. Periodic investigations requirement is higher, and upgrading for example, women in midlife require very regular treadmill testing. Once in 6 months if they have non-communicable diseases, or an annual for their cardiovascular risk assessment. And then for their MHT, if they are on MHT, for that evaluation. Because when we start off MHT, Archana, we will have one risk profile to start with, right? But when we go ahead, as women become older, probably one or two, there can be emergence of more risk factors. A woman may become diabetic after 2 years.
So I
Right,
think
she may
Madam
become
is correctly
hypertensive. So that is what is level 2, when more physicians are required and interventions are required. Yeah.
That is what I simplified, that level 1
Yeah.
can be done at a rural setup for the primary screening of the patient with minimum lab facilities or maybe ECG and X-ray. If you dig out some problem, please refer it to the level 2 clinic at a bigger centers where all the facilities are available to treat our patient. Regarding
Yeah.
MHT, this is a basket.
The level 1 also should have elementary cancer screening. I must say that, because I think level 1 should have elementary cancer screening. So we should not say that level 1 can be, it can be low resource setting, it can be low cost, but it cannot be suboptimal. It cannot be suboptimal.
Perfectly
Right?
said,
So,
madam.
yeah,
Because
it cannot be
those-
suboptimal. So we have to put in more. Yes.
Madam already
Yeah.
mentioned, Shamita ma'am, that we need a cancer screening. We can do by the pap smear, we can do by the villi testing at a low setup areas, and colposcopy can be offered at a level 2 center. So thank you for the inputs. I think we have
Yeah.
answered the delegates' maximum
And
queries.
for breast, I
Whatever we-
think self-breast examination has to be meticulously implemented. And if suppose a mammogram, a good digital mammogram not available, maybe a sonomammogram. And if there is a trigger for higher evaluation, FNAC, etc., then because breast cancer is something which we cannot miss. So that is another thing which we have to. And of course, the need for treatment because today we have given the message of treatment for menopausal symptoms, but we need to understand that even without symptoms, there is a role for MHT. Though, see, many of us have not taken MHT, but we feel that we should have taken with the emerging evidence which is coming up, right? So we'll
Thank
talk
you, ma'am.
more
I
about
think,
core
we
MHT.
have explained, Garimaji, we have explained level 1, level 2. I think I did, and Shobha madam also did.
Garima, we are trying to retrieve Dr. Hepsi's
No, I'll show it
presentation.
Trainer tomorrow because we need to go for the post.
Tomorrow we'll do
For the
that.
benefit
Yes.
of Garimaji, again, I'm telling you that level 1 is a low resource setup area where you can basically screen, find out the patient who is suffering from any NCD or comorbidities. And as madam said, you can do a pap smear, villi testing, you can do a self-breast examination, teach your patient, do a clinical breast examination so that you primarily screen in a low resource setup.
Oh, post-test
And
is not
target-
yet done, Archana.
No, post-test we have to start, but I think Garimaji is having some problem in understanding level 1, level 2. So I'm just explaining third
Okay.
time for her benefit.
Okay.
So
Okay.
yes, Guruji, gynecologist is the one who's doing the screening at the level 1 only. Menopause clinic is a clinic where we are sorting that a gynecologist is only setting up a menopausal clinic in association with cross pathies so that our patient is maximally benefited.
You know,
So
Archana, that's a very
colposcopy
interesting
can
question.
be done at, I'm
yeah.
just answering the question. Colposcopy can be done at level 2 because colposcope cannot be available at a low resource setting in every way. So Garimaji, we are expecting a low resource setting where you do the primary detection. If you are well equipped, its center can be labeled as level 2 as well. Mostly secondary or tertiary care centers are available in a better facility. So I think we have solved maximum queries.
Yeah, one input from my side, Archana, 1 minute. Somebody has asked, I think Himagouri has asked whether gynecologist at level 1. Only one input. Globally speaking, there are many countries where primary care physicians are trained. They self-train themselves to do level 1 screening for menopausal women. Okay, so actually there are guidelines available in general physicians websites where screening for menopausal women is there. So there is nothing that primary care physicians or general practitioners should not take up menopausal care. In fact, primary level 1 care can be taken up by them if they show enough interest, and they can be trained for that. What will happen then is that you would have hugely expanded your provider base for level 1, and that will improve references, it will improve diagnosis, it will pick up cancers early, it will identify more women for MHT, etc. So that was an interesting question. Suppose if gynecologist is not there in a particular setup, it can even be done by level. And then there is a concept in IMS also that we should be training general practitioners as well for menopausal care. So that is a good
Last
question there.
question,
Yes.
Shobha madam, last question. There was a question that breast doesn't come under gynecologist. I would
Ah,
like
that
to
is not
rectify
true.
it strongly that
Yeah.
I am a chief lead West Zone coordinator for breast committee, which Charu Bapai has been addressing. Last ICOG course we did for the breast health. See, whenever the patient comes primarily with any breast problem, she's going to come to me. So please
Yes.
stop thinking that it is not our domain. Yes, you can take the help of people, but we gynecologists also are trained and are specialized to detect the cancers early, and we can operate with certain limitations. Definitely, if you're trained, you can do that.
Yeah,
Also.
that is where the limitation
Training is
is.
what
Yes.
is important, as
Correct.
Madam already said. General practitioners also, IMS is offering CIMP training, and they can be having the experience. The gynecologist should be visiting to their place once or twice a month or week. They can also have a level 1 clinic. So I think we'll stop it here. And
Yeah, we will stop it here. Breast
post
screening
test.
is gynecologist domain. Surgery on the breast, you can always refer.
Always
But
depends on the
breast
training.
screening belongs to us, okay? Okay.
Debatable things. I will not enter into that. So Prerna, take over and start the
Thank
post.
you, Archana ma'am. Thank you, Sobha ma'am. Thank you, all the speakers, for a very, very steaming session indeed. And we have inputs from all around and queries from all the delegates as well. So we'll move on to our post-test session, that is assessment session. Do we have the link, tech partner?
Nilima ji,
have-
please share the link.
Archana ma'am, how much time they have? 10 minutes?
Yeah, 10 minutes. Yeah, that Nilima will set the timer. Don't worry.
I think she has set the clock already.
Yeah,
Test is on.
Just
Yeah.
we'll keep mute so that people are not disturbed. Thank you so much.
I think the time is up. So
Yes,
thank
Prerna, you
you.
can,
We can conclude, ma'am.
yeah, you have to read out the questions and the answers for the benefit of the people.
Ma'am, I'm
You
not
can
able
read
to.
out.
You can read, Nilima, please share the screen so that she can read out.
There must be no answers also must be there in that. So
She's sharing. Just give her 1 minute. She'll share. Yeah. So the
there it
one
is.
you can just read out.
So the very first question is, which of the following statements is not true about genitourinary syndrome of menopause? GSM is a chronic disorder not likely to improve without treatment. GSM can be clinically detected, and up to 70% of women experiencing menopause. Symptoms of GSM may include vaginal dryness, itching, irritation, and dyspareunia. Many women fail to link their symptoms with menopause, and only about
Only
1/4 of
the correct answer. Prerna.
yeah, okay. So
Only
the
the
correct
correct answer.
the correct answer to question number 1 is GSM can be clinically detected in up to 70% of women experiencing menopause. Question number 2 is
There is
all
an
the
echo. There's an echo. Are you in 2 devices? There is an echo.
no, ma'am, there is a track going.
She's in
All the
traveling
following
actually.
are true about use of vaginal estrogen to treat GSM, except the correct answer is rates of endometrial and invasive breast cancer and DVT are significantly increased with the use of vaginal estrogen. And question number 3 is, what causes curved or humped back? The answer to this is neither broken vertebra nor spinal bone. It's none of the above is the answer. So how can osteoporosis be prevented? It is daily exercise, adequate calcium, eat low-fat diet. It is both A and B, that is daily exercise and calcium and vitamin D. Which of the following activities can precipitate broken bones in osteoporotic individual? It is all the above. There is cuffing, lifting weights, and bending as well. The question number 6, metabolic syndrome is associated with increased risk of all except hypothyroidism. Metabolic syndrome in menopause is because of changes in levels of estrogen. We all know that. What is the best route of hormone therapy in metabolic syndrome of menopause? I can't see the answer to this. Can you scroll down, Nilima?
It's transdermal.
Yeah, it's transdermal route. Secondary sarcopenia can result from exercise is the right answer. Stages of sarcopenia take the following into consideration, except the bone strength. What is frailty? Definition includes the following, except gradual weight gain. Scroll down, please. Which is the incorrect answer? Out of it, reserve drug for low risk of fracture. Teriparatide. It is about teriparatide. So this is not a reserved drug for low risk of fracture. Select incorrect answer. Denosumab is a drug holiday is needed after 1 year of treatment. No, it is after 2 years of treatment. Oh no, denosumab, there is no drug holiday, they say. This answer is this is a wrong statement. So level 1 is suitable to have at low resource setting that we have already enumerated. And what facility is not included in level 1 care? It is mammogram. Mammogram is not included. What is not common to both level clinics is colposcopy is not common to both level clinics. Usually it is for the level 2. Which cardiovascular screening test is recommended for postmenopausal women to assess their risk? It is lipid profile is recommended for the postmenopausal woman to assess their risk. What effect does estrogen have on blood vessels? What does it decline during menopause? Impact on cardiovascular health. Estrogen causes vasodilatation and decreases blood pressure. So its decline leads to vasoconstriction and high blood pressure. It's a yesteryear's known theory. Which of the following conditions is not commonly associated with cardiovascular risk during menopause? Bleeding disorders is not associated with CVS disorders in menopause. Primary screening with HPV DNA is followed by which of the below under screen triage and treat WHO guidelines? Primary screening involves colposcopy. So we are done with the post-test session, and I hope everyone fared well. And it was indeed a very, very fruitful and a very informative, elaborative, and exhaustive course on menopause on day 2, which we have recently concluded. And if our dignitaries have any question or any inputs, we can welcome, or else we'll go for the concluding remarks. Archana ma'am, can we proceed for the conclusion?
Yeah, I think so.
Yeah, we'll conclude. Yes, Archana,
We can
please.
conclude.
Yes.
So I think Sarita ma'am is not there. So I am taking the privilege to conclude this session. We are waiting for the tomorrow's session where we'll have case-based scenarios, and there are another set of lectures for the
There is
training.
one concern. There is one concern in the test. One concern in the test, Archana, and that is
Yeah, I'm
question number.
looking forward to that. I'm just recording it,
Question
ma'am.
number 9.
Yeah.
Question number 9 about secondary sarcopenia. I think that there is an error in the. We are sorry for that, and we will see how we can sort it.
Rectify it, or we'll nullify that question.
Yeah, we will cancel the question so that
Question,
it becomes
we'll find
uniform for everybody. Yeah.
Tomorrow probably we'll have the answer to that, so don't
Yeah,
worry.
yeah.
And so it was a great learning experience for me as well as a convener, and thank you Shobha Kuti madam and the team.
Yeah, thank you,
Dr.
Archana.
Parul sir,
Yes.
Dr. Parag Binniwale sir, Dr. Sarita ma'am, Dr. Geeta Balshankar madam, and everybody else who has joined and being a part. My Master of Ceremonies, Prerna and Priya, you did a great job today, and all the delegates who participated. So, and our academic platform, Nilima ji and team ICOG. So thank you for everything. Looking forward to another session tomorrow. Have a good evening. Have a good dinner, healthy dinner after so much of talk. Try to avoid the foods which we are restricting you, and try to promote the detection and giving an ear to the menopausal lady next door and in your clinics. That is what is our aim. So a namaste to everybody and a good night to everybody. Thank you.
Thank
everybody
you.
for joining.
Thanks to Prerna and Priya for conducting well. Thank you so much. Thank you.
Bye-bye.
Thank you, ma'am. Thank you.
Thank you.
Bye-bye.
Bye.